So welcome today on this Sunday morning for the AOGD program on solving enigmatic endometriosis my way. So we have a galaxy of stars today. So to introduce them, I would like to hand the con to Ankita. Ankita, please take it over.
A very good morning to the esteemed dignitaries present with us today. Here we have an ocean of knowledge and a true academic extravaganza. Today we have a webinar on solving enigmatic endometriosis, my way, under the aegis of AOGD. At the outset, I welcome Dr. Mala Srivastava, President AOGD and Senior Consultant Robotic Surgeon, Sir Gangaram Hospital, to say a few words.
Good morning, everybody. I bring greetings from AOGD. It's my pleasure to be a part of this KOL series, Solving Enigmatic Endometriosis My Way, organized by Dr. Kuldeep Jain and Dr. Sudha Prasad Madam under the aegis of AOGD. Sir is taking great pains in organizing such wonderful academic activities, and we are hoping to have a nice academic feast today with star speakers and galaxy of faculty participating in the webinar today. It's my pleasure to introduce our guest of honor, Dr. Ramani Devi. Madam is the Vice President, Foxy. She is the Managing Director, Ramakrishna Medical Center, LLP, and Janani Trichy Fertility Center. Madam has won 10 gold medals during her UG and PG periods. She is the Chairperson of the Endometriosis Committee of Foxy. IMA National Best Secretary Award for the year 2006. Women Achiever Award by Citizens of Trichy. Member of Consensus for Endometriosis in Asia Pacific Region, Dr. APJ Abdul Kalam Award 2016, recipient of presented papers in national and international conference at FIGO, authorized 8 topics for books, and investigator in POIS, and she has been an editor and she has so many laurels to her credit. May I request Dr. Ramani Devi to address our August gathering. Madam, please.
Good morning, everybody. I feel really honored to be a part of this program on endometriosis, which is very close to my heart. And I should join this program. And I welcome all the participants, all the doyens in this field of endometriosis, Dr. Pai, Dr. Kamini Rao Madam, Dr. Alka Kriplani, and so many other people who are going to give the deliberations today. See, my only thing is, we know that in the incidence, probably the awareness among the consultants regarding the diagnosis of endometriosis is increasing, and thereby we are having more and more number of cases which are diagnosed at an earlier phase. And I would like to request that only thing is, we have to think more in terms of clinical diagnosis, clinical points, symptoms to that point towards the diagnosis, and so that we can start treating these patients at a much earlier stage. So we should reserve laparoscopy and other procedures only for patients who are really in need of it, and only once they should undergo laparoscopy during their lifetime. I think with this message, I congratulate the organizers for having such an excellent webinar. Thank you.
Thanks, Madam, for your encouraging words. It's my pleasure to introduce our next guest of honor, Dr. Mandakini Megh. Madam is the Chairperson, ICOG Foxy. Madam is International Vice President, MWIA Central Asia. She is the Vice President, AMWI Central Council. She is the National Vice President, Foxy, 2012-2013. Managing Council Member, MOGS. Deputy Director of Health Service, Government of Maharashtra, in charge of Family Welfare, RCH programs. Advisor to Officer in Special Duty, Family Welfare, Government of Maharashtra. Maternal Health Consultant for Government of Maharashtra. She has recent advances in postpartum care, book edited by her. She has received many laurels, many awards, and ma'am has always encouraged her in all the academic activities. May I request Dr. Mandakini, Madam, to address the August gathering, ma'am?
A very good morning to all of you. This fresh Sunday morning, nothing is going to stop all our gynecologists from having, meeting after meeting and increasing the knowledge. So thank you very much. At the outset, I thank AOGD, Dr. Mala Shrivastava, and all the organizing committee for involving me all the time and also enriching my knowledge and allowing me to think about having more and more certificate courses at the ICOG. So I bring greetings from ICOG. Again, I want to thank Dr. Sudha Prasad, my colleague, Dr. Kuldeep Jain, a very active person in the field of endometriosis, infertility. I can see Alka Kriplani. We are having a lot of bonding during our this endoscopy courses of ICOG. I can see my younger brother, Dr. Rishikesh Pai. Very nice to see all fresh faces. And Dr. Kamini Rao there, and Dr. Ashara, all of you, doyens of infertility practices. And I'm very, very honored, deeply honored that you call me. And we also, my Parag is also there, secretary. And we are very happy to give you the ICOG credit points all the time. Second thing, very important is that at ICOG, I want to say a few words about ICOG. That ICOG coming up with many innovative and newer schemes. First was online courses of reproductive medicine. All my colleagues here have been the faculty. They are the faculty of our courses. Sudha Prasad, Alka Kriplani, they know how this beautifully the courses are crafted and they are implemented. Since last 3 months, we are continuously doing this fellowship teaching program, and I'm so thankful to them that they supported me, and because of them the ICOG is getting such a high reputation in the academic field of OBGYN. So thank you friends for that support to the ICOG. Second thing, I'm coming to the certificate courses. So we had oncology certificate course, we had now we had this breast committee certificate course, adolescent certificate course online, very, very popular. And now I want to really, it's a pleasure to announce that with Ramani Devi, Asha Rao, we are going to have the endometriosis certificate course of the ICOG. And endometriosis certificate course is a 3-day course, and after the exam, the participants are given the certificates of the ICOG, which is very prestigious. So friends, with this knowledge, and last, Parag will say about elections. I just want to say a few words. I take this opportunity to inform all the audience that we have updated our website. You can see beautiful brochures of election. First time, all the candidates who are contesting for the governing council as well for the secretary post are put up there. You can actually have a look and you can decide. It's well in advance so that you are not jumbling at the time that whom to vote and all. So please visit our website, and also we are uploading latest newsletter. We are updating everything. So I think I request you to please visit the ICOG website, which is very, very updated. With this word, I congratulate Dr. Kuldeep, Sudha Prasad, Mala, and all the people here, faculty, for this wonderful webinars. Please keep continuing these wonderful activities of education and empowering the delegates. Thank you very much.
Thank you, madam, for your encouraging words. You are always such a pleasure to listen. I hand over now the floor to Dr. Ankita.
Thank you to the dignitaries to address us this morning. I now request Dr. Mamta Dagar, Ma'am is Secretary AOGD and Senior Consultant, Sir Gangaram Hospital, to say a few words and welcome the guest of honor. Dr. Mamta Dagar.
Hello, am I audible?
Yeah.
Yeah, I think some disturbance. So just a second, give me a second. Yeah. Well, very good morning to everyone. On behalf of AOGD, I welcome you all to this webinar on a very pertinent topic of endometriosis. And I'm happy to welcome our guest of honor, Dr. Parag Benewale, who has joined us today. And Dr. Parag, though, doesn't need an introduction to this forum, but it is my humble duty and honor to give a formal introduction of Dr. Parag. Parag is Secretary ICOG. He's a unit head and PG teacher at Kamla Nehru Hospital. He has been the Secretary IOCG. He has held several important positions in the past. He is also the President Menopause Society Pune, National Joint Secretary IMS 2017-18, National Website Editor FOXY 2011-17. He has had several numerous important publications which are to his credit. And without further delay, now I hand over to Parag Benewale to say a few words, sir, to this forum. Thank you, sir.
Parag, are you there?
Parag is speaking, cannot hear you, Parag. We cannot hear you. I think the volume is less.
Parag, we can't hear you. Ankita? Ankita?
Yes, sir.
I think there is some problem with the Dr. Parag's audio, so we can continue with the inauguration and then proceed further.
I request everybody to join us for the inauguration today this morning. Sana, can you play the video, please?
Hello.
Yeah. Parag is there. Yeah. Now we can hear you.
Yeah. Thank you. Thank you, Kuldeep, for the invitation. Thank you, Mamta, for those kind words. I bring greetings from ICOG, the Indian College of OBGYN, which is the academic wing of FOXY. And it's a pleasure to be here this morning virtually in Delhi with stalwarts like Dr. Kamini Rao, Dr. Alka Kriplani, a dear friend, Dr. Rushikesh Pai. I must compliment AOGD for their continuous webinar activities. I am practically giving credit points every day for AOGD, and this is my second visit in this week virtually to Delhi. Endometriosis is something which was so different 30 years ago. I remember vividly Dr. Narges Motasha talking about endometriosis way back in 1990, and at that time all of us thought that what kind of this disease is this, and this is not for our country. But 30 years down the line, all of us are here learning about endometriosis and discussing various aspects of it. So my best wishes for the program, and to you, Kuldeep. Thank you very much for the invitation.
Thanks. Sana, inaugural video, please.
Dipajyotir
Now I start with the academic session. I invite Dr. Sudha Prasad. Ma'am is President Indian Fertility Society and Director Matritva Advanced IVF and Teaching Center. Ma'am has been a teacher for more than 34 years. She's past president of TOG, vice president, FOXY, and recipient of various awards like the State Award by Government of Delhi. Dr. Sudha Prasad.
Thank you very much, Ankita, and very good morning to all of you. This is my privilege, great privilege to be here. And AOGD is doing so many good, nice, fantastic activities. I really want to congratulate Dr. Mala Srivastav. I would like to introduce Dr. Kuldeep Jain, which is a very well-known personality in AOGD, in FOXY. He has done a wonderful job for the Indian Fertility Society, and he is the past secretary and the president also of the Indian Fertility Society. He is the director of KJ IVF Academy of Reproductive Medicine in Delhi, program director of ART Center, Faridabad. He is organizing secretary of LOC IFFS. He is looking after the international wing of Indian Fertility Society and members of many other academic wing. And the most important is he's working on endometriosis for last 3 years in FOXY. He was a chairperson, and now he's contesting for the vice presidentship from the North Zone FOXY. And I hope, and my best wishes are with him.
Thank you, Dr. Sudha, for your kind words. It is really a pleasure to see all galaxy. If we start naming, then there is nobody left actually. As far as the infertility is concerned, we are having Dr. Kamini Rao here. We are having my dear friend Rishikesh Pai. We are having Dr. Bhaskar Paul. We are having Professor Alka Kriplani. We are having Dr. Asha Rao and Dr. Reddy from Chennai. They are all stalwart. They are all key opinion leaders. And let me explain the concept of this program. Why key opinion leader meet is required. We are having guidelines, we are having recommendation, but when it comes to the challenging subjects like endometriosis, we always look forward to listen to the key opinion leaders who can actually guide all gynecologists for their day-to-day dilemmas, which are actually involved in subject like endometriosis. We know that endometriosis is a disease of dilemmas and controversies. Whatever guidelines are available, whatever recommendations are available, but when it comes to the actual practice, the scenario is really different. And every one of us is trying to get the best outcome through the available literature, through the experience of seniors, and through the experience of these key opinion leaders. So that is the concept. When it comes to the benefit of the patient who is suffering actually with endometriosis and infertility, there are a lot of dilemmas how to go about, whether we have to go for surgery or we have to go for ART directly, whether we require medical management. So there are a lot of questions in the minds of everyone. And today we are assembled here to clear these doubts, and we are directly actually listening to the key opinion leaders on different aspects, how they are managing their cases of endometriosis in day-to-day practice. So I really hope that this summit is going to be very, very useful to all our attendees. I congratulate and I welcome everyone to be here, to be part of this program. Before I proceed further, I take this opportunity to seek your blessings and support in my coming election as Vice President Foxy from North Zone. I have been serving Foxy for last 35 years in different roles. My last assignment was really very fruitful as Chairperson Endometriosis Committee, Foxy, which ended in 2019. And during that period, I really saw a lot of enthusiasm among all Foxians throughout the country. And that gave me impetus to work more and more for all Foxians in a bigger role. So now I am presenting myself as Vice President Foxy, North Zone, as your candidate. So please support me, vote for me from 1st September to 10th September incoming election. With that, I invite my first key opinion leader. As you know, that there are a lot of dilemmas which are actually there, starting from the diagnosis, management, and follow-up in endometriosis. So we will start from diagnosis. What are the dilemmas in the diagnosis? And a person who is actually at the helm of affair of Endometriosis Committee, Foxy, currently she is chairperson. I welcome Dr. Asha Rao. She will be deliberating how she proposes and how she is managing these cases, how she is diagnosing endometriosis, what are the problems which are there, and how she overcome. Dr. Asha Rao is Director, Rao Hospital, Coimbatore. She is currently Chairperson, Endometriosis Committee, Foxy. She has delivered first ICSI baby of Coimbatore and first vitrification baby of Coimbatore. She is associated with a lot of activities at the local, at the regional level, as well as at the national level. So here I present Dr. Asha Rao for discussing the diagnostic dilemmas in endometriosis, how she is solving. There are few questions which comes to my mind, and I will like Dr. Asha Rao to answer these questions, because these are the questions which are everybody's in mind. There are a lot of diagnostic modalities, but when it comes to selecting a diagnostic modalities, what are the best modality for diagnosing endometriosis in your practice? When a patient presents to you with a chronic pelvic pain in abdomen and you find a cyst, what are the various differential diagnoses? And is there any best way to diagnose adenomyosis? And many patients, they present at an advanced stage, like this patient who is having 8-week pregnancy with 10 years of infertility, with history of past endometriosis, now coming to with history of hematuria. So how would you diagnose? What is the cause? So these are some of the questions which I hope that Dr. Asha Rao will be able to answer, and there will be many more questions from the audience which she will be happy to answer. Dr. Asha Rao, please.
Thank you, Dr. Kuldeep, for your kind words. It is my privilege and honor to be associated with such a vibrant meeting with so many stalwarts, and I thank you for the opportunity. Diagnosis of endometriosis is full of dilemmas, because endometriosis is a riddle wrapped inside a mystery, and though the disease is more than 150 years old, we still have so many different etiologies, dilemmas in diagnosis, and disputes in management. It is a chronic inflammatory condition, and it presents as under hormonal, immune, and systemic stimuli, and presents with 3 phenotypes: superficial, ovarian endometrioma, and deep infiltrating endometriosis. Here you can see by Chaperon, beautifully depicted superficial lesions, endometrioma, and DIE, and adenomyosis also is associated with 30% of these patients. And 1 in 10 women have endometriosis during their reproductive years, but there is a colossal delay in diagnosis. So almost 1 year before they reach the consultant with their queries and problems, and another 6 to 7 years are spent before they reach a good surgical diagnosis.
I think it has come on my mail, so I will just send it to
20%
Sana.
of infertile women, 75% of women with chronic pelvic pain, and 60% of women with dysmenorrhea seems to be having endometriosis. And globally, around 176 million, and in India, more than 26 million are suffering from endometriosis, and it decreases the quality of life. So a proper early diagnosis and right management is very important. So diagnosis, the history, symptoms, and signs are also very important because they are site-specific. Dysmenorrhea, dyspareunia, dysuria, dyschezia, DUB, diffuse abdominal pain, difficulty in conception, all these point to a particular organ. So we have to take a good history taking and a good physical examination, look for nodules in the polydouglas, nodules in the vagina, fixity of the uterus. All these are very important because people are forgetting to do a proper examination these days. They just say, okay, send up for ultrasound. And we may miss very many important findings. So examining patient also is very important apart from history taking. And from the modalities that are available to us, tumor markers are not of great significance, whereas ultrasound, laparoscopy, and MRI are the best modalities available. Though laparoscopy is the gold standard for diagnosis of endometriosis, today as we stand, transvaginal sonography seems to be the first line of management for diagnosis. And next, whenever there is doubt, we can do transrectal ultrasound, MRI, TAS, etc. Regarding the superficial lesions, it's very difficult to diagnose. You cannot delineate by abdominal or vaginal ultrasound, and you can, and by MRI only if it is more than 5 millimeter. And correct site-specific diagnosis is fundamental in defining the optimal treatment strategy for endometriosis. Non-invasive imaging methods are required to map accurately the location and extent of endometriosis. So as you do the non-invasive diagnosis, which all of us prefer and not laparoscopy, we have to try and see which is the site that is affected, and it's very important for the treatment also. And as per chaperone, we have to try and avoid diagnostic laparoscopy as much as possible in these women. Try to diagnose more and more by ultrasound and occasionally MRI if needed, and laparoscopy only more and more for definitive treatment. The word diagnostic laparoscopy should be replaced by therapeutic laparoscopy as much as possible. And do not use pelvic MRI as the primary investigation to diagnose endometriosis in women with symptoms or signs suggestive of endometriosis. Consider pelvic MRI to assess the extent of deep endometriosis involving bowel, bladder, or ureter. And you need a specialist who is trained in imaging these things. A proper reporting is very important. Machine may be good. The man behind the machine also is very important for ultrasound as well as MRI. And what are the different conditions that mimic chocolate cyst? When a woman comes to you with abdominal pain, the first and foremost commonly seen thing would be corpus luteum, which is unilocular, and you can see the echogenic fibrin stands, clotted blood, cobweb appearance, and less vascularity. This is another beautiful corpus luteum. You can see very typical appearance. You should not mistake it with the endometriosis. This is hemorrhage, hemorrhagic cyst versus chocolate cyst. You can wait for a month and see after the menstruation, 1 or 2 menses, I'm sure the hemorrhagic cyst would regress. Ovarian dermoid, the snail shell appearance, with cystic and solid areas, sometimes can be confused for an endometriotic cyst. And ovarian torsion, enlarged ovary, heterogeneous echotexture, peripheral cyst, twisted vascular pedicle, you will see a whirlpool sign. And pelvic abscess, complex cystic mass with low-level internal echoes, thick walled, and Doppler shows sometimes good vascularity because there is inflammation. In fact, this was a lady who had an abscess in the chocolate cyst after she was operated elsewhere.
and she was drained, and she came with a pelvic abscess in a chocolate cyst. So what are the ultrasound features of endometrioma? Low level echogenicity, few septae, there may be 3 or 4 compartments, thick wall cyst. Sometimes you will see vertical fluid levels, echogenic flex, scattered vascularity, absence of papillations, and poor blood flow. This is a very typical chocolate cyst, thick wall cyst with a ground glass echogenicity, and you can just see about 3 to 4 compartments, no papillary structures or no detectable blood flow. So this is the X-ray guideline for ovarian endometrioma. Sometimes you see hyperechoic foci. This could be because of cholesterol deposits, you can see here. Sometimes when you open a cyst, you see it even like a meconium plug, thick black colored deposits. And sometimes you see a vertical line, vertical fluid level. This could be because of fresh hemorrhage. The echopore area is the plasma, and this is the debris. So the fluid interface can be seen vertically. And acoustic streaming sign, you can have calcified foci within the cyst. Acoustic streaming sign can help to discriminate from mucinous serous cystadenoma, but presence of this does not really exclude endometrioma. So sometimes you have a tug, is this endometrioma or is it a cystadenoma? A fresh hemorrhage in a chocolate cyst. This can also produce a confusing appearance. So a lot of experience is required to say, what is this exactly? Is it a chocolate cyst or is it a cyst? This is, you see a solid area in a chocolate cyst. Quite confusing. It could be a retracting blood clot, concave margin, absent blood flow. Discriminating feature is ground glass echogenicity of the cyst and absence of papillations and no detectable blood flow. A decidualization of endometriosis in pregnancy is quite challenging for diagnosis. So it requires expectant management and serial monitoring, because you will even see blood flow like this. And if there are papillary structures within a cyst, once again, you are quite alarmed, because once in a way you might come across endometrioid carcinoma or also clear carcinoma. So you must study this very well, look for the blood supply and make a proper diagnosis, and if necessary, take a second opinion. 3D ultrasound may not make wonders for chocolate cysts, but it helps you to define the borders very nicely. You can see the peripheral blood flow, you can see the follicles properly, so it adds to the diagnosis. But as Doppler is important, scattered vascularity at hilum is typical of endometriomas. Non-endometriomas have rich vascularization. So Doppler is helpful to see the vascularity in the cyst and differentiate it from other cysts with active blood supply. This is one of our young patients who came at night with severe abdominal pain. She was married for 1 year, and she said, I had very little pain earlier, but now I have severe pain after marriage. This is what everybody says. I was quiet earlier, but now I have pain. And we saw a right ovary enlarged with 8.7 into 6.4 centimeter, the typical ground glass appearance. And the left ovary also had a small chocolate cyst. So we made a diagnosis of bilateral endometriotic cyst. And I do not know whether this, yeah, here you can see the right ovary and also left ovary with the chocolate cyst and beautiful fallopian tube. There were no additions at all. So it was surprising to see a cyst, bilateral chocolate cyst, no additions, good fallopian tube, married 1 year, so with no male factor. So we took her up for IUI after 2 months, and now the child is more than 1 year. This is the person. Here you can see a thick wall chocolate cyst. And there is some sort of, we do not know, it is a leak of the fluid. This was a kind of picture, 9 centimeter. We took her up, and she also has a myoma. We took her up for laparoscopy during our star endogyne conclave. In fact, Dr. Sandesh Kade was operating on this lady. You can see some adhesions here, and there's a fibroid in the uterus. And after releasing the adhesions, we could see the Deceased also had vascularity. Yeah. So this peri-ovarian tissue on probing, we saw a lot of pus draining from that. Even from the ovary, it was the pus that was draining. So it was a tubo-ovarian mass with pus, ovarian abscess, which was actually drained, it was becoming a psoas abscess. It was getting into the abdominal wall. So we had to excise this ovary. She already had 2 children. We did the right salpingo-oophorectomy, and pus was also sent for culture. It came as no tuberculosis, came as separative salpingo-oophoritis. So it looked typically like a chocolate cyst, but it was an ovarian abscess. These signs, if you see, it is suggestive of severe form of disease because there could be adhesions. The ovaries are kissing behind the uterus, so it suggests grade 4 endometriosis. So you have to counsel the patient properly, saying that you could have advanced disease. So be prepared for sometimes maybe a tubal disconnection. If there's a blurring of ovarian margin or inability to mobilize the ovary on palpation or increased distance from the probe, also you suspect ovarian adhesions. Today, we have the right ways of diagnosing endometriosis. We have this IDEA group, the International Deep Endometriosis Assessment Group. So they are bringing a lot of guidelines how to make a good assessment of endometriosis and especially deep infiltrating endometriosis. The first step is routine evaluation of uterus EDIXA. Look for the sonographic signs of adenomyosis, presence or absence of endometrioma. This is the first step. And second step is site-specific tenderness is a soft marker, and also look for ovarian mobility. There are definite methods of doing it. Third is assessment of status of Pouch-Douglas using real-time ultrasound-based sliding sign. The sliding sign has been depicted beautifully. And even in our own clinic, my sonologist does it very regularly. Fourth step is assessment of deep infiltrative endometriotic nodules in anterior and posterior compartment. And everybody should follow these methods so you do not miss out on anything. Here you can see already step 1, uterus has a comma-shaped endometriosis. This is adenomyosis. There are flapping signs, flapping cell signs of adhesions. There is a hydrosalpinx. So obviously she is a case of grade 4 endometriosis and definitely with adhesions. This is once again flapping cell sign, pelvic adhesions. So sliding sign, how to do it? You can do it for the antevert the uterus and look for the adhesions between the posterior surface of uterus and the sigmoid. Then you can also do it for the retroverted uterus. I think explaining it is beyond the scope of today's talk. Here there's a normal sliding sign. You can see it sliding beautifully. So uterus posterior wall is not attached to the bowel, whereas here it did not move well. So it's an abnormal sliding sign. So this is one of our young patients. You can see she has bilateral kissing ovaries and the sliding sign was negative. And this is what we saw at laparoscopy, grade 4 endometriosis, and ovaries are kissing, bowel is attached. So she is a case of deep infiltrative endometriosis and grade 4 pelvic endometriosis. The same girl, she was just married for 2 years and she was asymptomatic. I couldn't believe it. She was the daughter of a medical representative, educated girl, came for infertility when she was married for 2 years, and we took her up for laparoscopy. This is what we saw: adenomyosis, hydrosalpinx, pelvic adhesions. So we had to do, in fact, a tubal flipping, minimal adhesivolysis. We just drained the cyst. We did not really excise the cyst, and we have given her GnRH depot and asked her to come back after 3 months for IVF. So this sort of pre-operative assessment and counseling the patient is very important. Otherwise, if you just go and do a tubal flipping or excision of the tube, the whole family is going to jump on you. So kindly do a methodical check and try to assess adenomyosis, hydrosalpinx, adhesions, how much you can save the ovary, not save the ovary, or whether you are going to just do a minimal procedure. All these have to be counseled. The fourth step is to assess for DIE, the deep infiltrating nodules in the anterior and posterior compartment. A slightly filled bladder facilitates the examination for any endometriotic nodules near the bladder. And you can also fill the vagina with a little water and also put a gel in the condom before which covers the probe, and you can do a good examination and tenderness guided examination for the nodules of DIE. These are the common sites: bladder, rectovaginal septum, and in front of the rectum. These are the common sites for DIE. And there are very many methods how exactly to look for the nodules in the posterior compartment, the nodules in the anterior compartment. This is a bladder endometriosis, bladder dome. So, how to do the examination of the bowel? There is comet sign, Indian headdresser sign, pulling sleeve sign. Is full of signs. So you can assess properly the attachment, whether there is a bowel involvement, what is the extent of lesion and what is the extent of adhesion. We did not really do MRI in all the patients. Only if you have a very special doubt, you can go for MRI. Overall accuracy was similar in both techniques. MRI showed comparable results with TBS in deep infiltrative endometriosis, but not as reliable as TBS for diagnosing POD obliteration, which is crucial for the surgeon. So sometimes you can do a bowel preparation and use a contrast, but you have high cost for MRI, whereas ultrasound is available to everybody and we have to use our expertise. So TBS should be the first line of imaging in suspected endometriosis. This is one lady who came to us, married 11 years. She came with early pregnancy of 8 weeks. She gave history of surgery for endometriosis about 8 years back, and she had a failed IVF elsewhere, and now she had a spontaneous conception at the age of 33 years. She came with intermittent hematuria at 8 weeks, and ultrasound showed this lesion between the cervix and the bladder. And when we sent her to the urologist, she said, no, I do not want to do a cystoscopy because she was just about 8 weeks, very precious pregnancy, do not want to disturb her physically and psychologically. And we did a centrifuge the urine for malignant cells. It was found to be negative. And later, when she was about 4 months, we did a cystoscopy, took a biopsy. It was proven to be bladder endometriosis. Pregnancy was there, enough progesterones were being secreted. We just continued the pregnancy. And she had a full-term LSCS that was at 37 weeks. And we saw that there were lesions, whitish lesions all over the peritoneum. The cecum was matted. And we took the biopsy from these white lesions. It came as decidualized endometrial deposits. And tuberculosis was ruled out. And when the child was 6 months, I told her, you kindly have a intrauterine device, LNG-IUS. She refused it. And she came to us after 3 years. She was a happy mother for 1 year. Then at the end of 2 years, she had severe abdominal pain and projectile vomiting. She had gone to a good gastroenterology department. Coimbatore is full of laparoscopy units. And they had diagnosed bowel obstruction and they had done a right hemicolectomy. And the report came as endometriosis. And the story did not end. She came 1 year after this back to us saying that she has a recurring pain again, and the doctor has suggested a second laparoscopy to see why she is getting pain. And by ultrasound, she did not have very many signs apart from her pain. It did not show any suggestion in favor of bowel obstruction, no major lesions. So now we have put her on Dynogest. She is on Dynogest for last 2 years, and she's a very, very happy woman now. She came 2 days back, and that's how I was reminded that she's a very important, interesting case. She has gone through a full spectrum of lesions, because when she had a laparoscopy 10 years back, she was grade 2 endometriosis, and she went into various complications of complications of endometriosis. And today, Dynogest ultimately has come to her rescue. And a few words about diagnosis of adenomyosis, which is becoming more and more common. Not a disease of Paris women above 40 anymore. It is seen in about 20% of women coming for assisted reproductive technology. You do not need MRI for everyone. A globular asymmetric uterus with irregular cystic spaces. You can see the posterior wall is bulging more than anterior wall. Striation, cystic spaces, echogenicity. Poor definition of the endomyometrial junction. These are all the signs of adenomyosis. But you should diagnose adenomyosis at this stage and not at a late stage like I showed in the 2D. Because every patient with recurrent implantation failure or early miscarriage, you have to look for adenomyosis and prevent them from further problems. So this is endometrium, myometrium, and the junctional zone. And this is the early deposit of adenomyosis. This is the focal adenomyosis. And if you suppress it at this stage, you can definitely suppress them and they can even have a natural conception. This is once again focal adenomyosis, you can see. And this lady was undergoing another procedure, so she also underwent a focal adenomyometry and now she has had a baby. This is focal adenomyoma, which mimics a myoma. This is in the posterior wall of the myometrium. And you have to differentiate from fibroid. The indistinct margins in adenomyoma, well-defined margins in fibroid, heterogeneous echogeneity in adenomyoma. Fibroids are mostly homogeneous except when they are degenerated. Internal vascularity in adenomyoma, peripheral vascularity in fibroid. And loss of myometrial tissue, maybe fibrosis around in adenomyoma. And it is different in, but very many times we have shifted the ultrasound machine to the theater and Dr. Rao used to, tell my radiologist, come and tell me where is the myoma now, because he says, what I'm seeing is adenomyoma and not the myoma. So the debate continues. But most often today, we are able to diagnose adenomyoma or adenomyosis much better than what we were doing in the previous days. Thanks to the E8 machine that we are having, makes a lot of difference. And you can study the normal junctional zone. The junctional zone is barely 4 to 5 millimeter in non-pregnant normal women. If it is more than 10 millimeter, suspected adenomyosis, more than 12 millimeter, it is definitely adenomyosis. So look for thickening of the junctional zone, focal adenomyosis, and diffuse adenomyosis. I can go on talking for another 15 minutes about adenomyosis. So let us think endometriosis and let us fight endometriosis. So let us think adenomyosis and fight adenomyosis. So this is the motto of my endometriosis committee this year, to spread awareness on proper diagnosis and right management for endometriosis and adenomyosis. Thank you, Dr. Kuldeep Jain, for having given me this opportunity. And whoever has a question, kindly put it in the chat box. Thank you all.
Thank you, Dr. Asha, for wonderful insight in the diagnostic dilemmas involved in endometriosis and adenomyosis. We will be taking questions at the end of the session. So I request all attendees to put their questions in the chat box. My next key opinion leader is none other than Dr. Kamini Rao. When it comes to the decision making in endometriosis and infertility, you are always in a dilemma whether the patient who is sitting in front of you is a good candidate for expectant management, or IUI will be helpful, or for that matter surgery will be helpful, because there are a lot of ifs and buts. Whenever you are deciding the management, you have to keep in mind so many things and you have to take so many things into consideration. It becomes a real challenge for any clinicians who is involved in the infertility management as well as the management of endometriosis. So I present to you Dr. Kamini Rao for her lecture on decision making in endometriosis in clinical scenario. Dr. Kamini Rao doesn't require any introduction to this august audience. She has been a very well-known figure of FOXI. She was past president of FOXI. She was past president of ISAR. Currently, she is medical director Milan, the Fertility Center. She is chairperson of National Register of ART and Clinics and Banks. She is Padma Shri awardee from Government of India. So beyond that, she is a very, very humble person. She is a great academician and excellent orator. So I present to you Dr. Kamini Rao. her questions which I will like to ask from her. These are some of the questions which comes to my mind. What are the factors you take into account while deciding for surgery, IUI or IVF? Because that is one thing which we have to keep in mind, that the particular procedure should be helpful in giving the maximum fecundity. So how she is doing that? Is there any specific protocol she is using for stimulation in these patients? What is the counseling goes before you decide for the surgery or for IVF or IUI? And what is your experience regarding outcome in endometriosis patient in comparison to other infertility factors? So, Dr. Kamini Rao, the floor is yours.
Thank you very much, Dr. Kuldeep Jain. And of course, all the best for your elections. And I hope you do occupy that seat. You'll do a lot of good for the organization as well as you've done so well for the IFS. But can I have the questions on the screen so that I can speak on these questions? Sana, can I get, yes, the questions, all right, so that I can actually address one by one. Now, the first question was, what are the factors you take into account while deciding surgery, IUI, or IVF? So, first and foremost, again, one size does not fit all. No, just don't change it till I ask you to change it, please. Yes. The factors that I would take into consideration while you're looking for surgery is how much is the pain. Now, if pain overrides every kind of treatment, then yes, surgery will be my first choice, because I would like to relieve her of the pain, because I cannot have a person with such severe pain and then start looking for, will you like to have a baby? An example of this was a person who had come with such severe pain into the clinic at 2 o'clock in the early morning, when one of my registrars in the hospital was saying, look, if you can just wait and just bear this pain and take some the analogs, then we can do some IVF for you also, and then we can think about any other surgery. So the woman got up and said, look here, what the hell do you think? Here I am suffering with pain, and her childbearing is the last thing on my mind. So I think a little bit of understanding on what the woman wants is also very, very critical over here. So surgery will be my choice only where the pain is absolutely unbearable and where medical treatment has failed in the past. So the other thing is the age factor. And if the age factor is beyond 35, and the fact that, you don't have too much of an ovarian reserve, or the fact that you've had previous surgeries and this is a recurrent infection or a recurrent endometriosis, that means the ovarian reserve is going to go lower and lower. And the fact, has she had previous children or not? Has there been only abortions? These are some of the things I would look before I can go and pick up one or the other form of surgery. So one size will not fit all. Multiple factors will be taken. Personalized medicine is what I would use in this case. So this is something I would do for both IUI and IVF. So age factor, AMH factor, previous surgeries, recurrence, pain are some of the factors that I would look at before I can take a decision and say, yes, I will go ahead for this or that. Now, is there any specific protocol you use for stimulation in these patients? The answer is, again, yes. Now, many a time we've seen that when you give in women who have got endometriosis, rather than giving a clomiphene citrate treatment for the younger patients and where there has been endometriosis, letrozole, aromatase inhibitors work better. It also helps to reduce pain, but also helps you to get better pregnancy rate and also better stimulation if you give letrozole with gonadotropins rather than clomiphene citrate. This has been known to help in these situations. Otherwise, the use of gonadotropins will be the same in both these cases. The importance over here in stimulation is that do not leave it for too long and say, you try naturally for 6 months and then come back, because she may come for she'll come back to you with again large endometriotic cysts, and then you may have got no other options, but that would compromise the quality of eggs and also the ovarian tubal relationships, and therefore can result in mechanical infertility, and also will involve with quality of eggs and quality of embryos as well. Now, the third thing is what counseling do you give these patients? I think these patients are really in trouble, frustrated women who have tried everything, sometimes even suicided. So therefore, these patients have to be given empathy. And you must talk to them in a positive way rather than to say, okay, fine, just forget everything, just go and adopt. Now, if they had to go and adopt, why will they come to you? So first and foremost, you have to give them a patient hearing. Hardly have they come and sat down, they've not even warmed the seat. The first thing you will start, how about donor eggs? Because you have this repeat endometriosis, so you just go for donor eggs. I think why you're just troubling yourselves with all this. The next thing you'll see that the husband will have married somebody else. So you have to be very clear in this, that how much do you tell the woman on the first go? You have to assess the couple. You have to assess the husband more than the wife over here, because many a time the wife doesn't say everything. She is very, very worried as to what would be her married life after this. Her dysmenorrhea, her dyspareunia, these are the things that you will have to elicit from her. Deep rectovaginal endometriosis, these are some things that you will elicit in her history. So counseling will have to be directed as to what aspect of endometriosis that we will have to counsel. And of course, adenomyosis. There could be concomitant fibroids along with this. So therefore, find out what are the other factors. Now, there would be an age factor, there would be a marital factor, there would also be a mother-in-law factor, there would be a husband factor, there would be social factors, there would be a psychological overlay, and of course, the endometriosis factor. So you'll have to take all this into consideration, but do not be playing God. Do not be judgmental. Because at the end of the day, these patients are coming to you for help. And at the end of the day, if you just put a death knell on them and say that you can never be parents, then even if they can become parents, that little hope that they had will also go away. So I would suggest to you that this could be a series of counselings that you need to do to them, bring them back to normal. Many a time you will find that just putting them on a continuous dose of letrozole for approximately 3 months in these cases does a world of good, because we've probably thought that endometriosis, the treatment would always be of suppression to such an extent that they go into menopause. Whereas in letros, it will be of stimulation. So we should be very clear that if you are looking in fertility treatment, look at stimulation rather than suppression. That would be a slight difference in the way you will look at endometriosis and in counseling. The other thing that you have to look at when you look at the experiences regarding the outcome of endometriosis in patients in comparison to other infertility factors, I think endometriosis grade 1 and 2 have very similar results when compared to other factors. It's only the grade 3 and 4 which really have dismal factors. So if you have reached grade 3 and 4, obviously you've got very little time. You need to work on it. Cumulative pregnancy rates give a better pregnancy rate in these cases rather than in single IVFs. You must tell them you may have to pool your cases and then maybe down-regulate them for some time. Frozen cycles give you better results than fresh cycles. Obviously, you'll have to do some selection of these embryos, and hopefully, at least the male partner would have better quality sperms. So if you have a single factor of only endometriosis, that is for the woman, and all other factors being normal, then yes, I think you would have definitely a lesser chance of success in infertility in grade 3 and 4, but certainly the chances will be better in single pathology problems rather than dual pathology problems like male and female factor infertility. Okay, so can I get to my slides, please? Can I start? Yeah. So let's just look at the management of infertility in endometriosis. I think Asha has given us a very good illustration of the general endometriosis management, and we'll go into the infertility endometriosis. Next slide, please. See, we know endometriosis is a major health problem worldwide. In fact, this is a cancer without a name, because we know fully well that it behaves like a cancer, and we also know that we can't call it a cancer, but in all ways it behaves like one. Chronic estrogen dependent inflammatory disorder present in almost 50% of women with pelvic pain and infertility. It affects over 100 million women, look at the extent, and teens worldwide. 6.7 to 11 years from symptom onset to surgical diagnosis and treatment. Early diagnosis and treatment can reduce uncertainty of diagnosis, discomfort, disease progression, and complications. Most of the time, by the time it goes from the routine GP to the routine gynecologist to the specialist, we have lost almost 5 valuable years to 7 years, and that's where these stage 1 and 2 land up to stage 3 and 4. So if we are able to identify them early, your pregnancy rates would be very good if we are talking about infertility management. Next slide. So look at all these lesions here, the red lesions, the hyperemia lesions, and of course the blue-black lesions here. And we have also the red lesions, etc. These are all some of the things which you all know already. Next. So in diagnosis, of course, laparoscopy is a gold standard. Laparotomy we don't normally do for a diagnosis. Confirm a positive laparoscopy, then a laparotomy and histology. It's inconclusive because CA125 does give a slightly higher level even in endometriosis. TVS for an ovarian endometrioma with a cyst and ground glass echogenicity. TVS is useful for identifying or ruling out rectal endometriosis. MRI to diagnose peritoneal endometriosis is not well established. Then cystoscopy, proctosigmoidoscopy to assess ureter, bladder, and bowel involvement in rare cases. Next slide. So what would the effect of this endometriosis, and why does it cause a problem on fertility? The distorted pelvic anatomy, altered tubal milieu, altered peritoneal fluid, hormonal dysfunction, hyperprolactinemia, ovarian dysfunction in the form of either follicular growth, anovulation, luteal unruptured follicle, and corpus luteum insufficiency, altered follicular function, oxidative stress, altered endometrial function, autoimmune dysfunction. Very, very important. This seems to be an important factor. Next. So the changes associated with endometriosis may affect the ovulation and the corpus luteum, the oocyte quality, oocyte capture, sperm transport and function, fertilization, embryo development, implantation, and of course, we would look at the next slide. Yeah. So which treatment do we choose? Do we take the medical treatment or do we take the surgical treatment? The dilemma still is on. I mentioned earlier that the severity of the pain, the patient's age, grade of endometriosis, desire for fertility, and need for the infertility treatment is important. These are some of the factors all of us need to look at. And then, of course, we must ask the woman what she desires. We just can't say now you finished your age, now you've just got to get that uterus out or you've got to get your ovaries out. I think ultimately it is what the patient wants. The job of the doctor is to give her all the options, and the job of the patient is to take that decision once all your options are put across to the patient. Next slide. So there is no definite answer. Next. Next. So, role of lifestyle in infertile patients with endometriosis. Since estrogen is an estrogen-dependent disease, so any lifestyle that produces decrease of estrogen production may reduce the risk of endometriosis. Simple. Correlation between BMI and the risk of developing endometriosis is still controversial. Regular exercise lowers estrogen levels and may benefit women with endometriosis. Caffeine and alcohol both increase estrogen levels and may thus increase the chances of endometriosis. Next slide, please. So, after surgical treatment, allowing 12 months of spontaneous pregnancy depends again on the stage of the disease and of pelvic affection. Expectant, you can, medical, next, no role of medical, no role acts as a contraceptive, okay, the medical treatment. So there is no medical treatment after surgical treatment, but in expectant endometriosis may or may not alter the effect. So controlled ovarian hyperstimulation and IUI may be tried immediately after surgical treatment, may be effective if performed shortly after laparoscopy. Art may be, the outcome may be affected. It's important for us to understand that we have to get the pregnancy as quickly as possible. Next slide. So medical therapies are, of course, progestogens, combined estrogen progesterone pills, gonadotropins, releasing hormone, gonadotropin releasing hormone antagonists, danazol and aromatase inhibitors. Next slide. Next. Yeah. So hormonal treatment, that is contraceptives, progestogens, anti-progestogens, GnRH agonists for endometriosis infertility. The HRA guidelines and the SRM committee report suggest that suppression of ovarian function ineffective to improve fertility. Grade A evidence. Effective for relieving pain associated with endometriosis, and there is no evidence that it improves the fertility. Next slide. So GnRH agonist treatment may be effective in improving fertility because it increases the natural killer cell activity, increased antibody levels resulting in higher peritoneal fluid levels of interleukin-1 and decreased levels of TNF-alpha, and also cell apoptosis and obliterate the embryotoxic effects of peritoneal fluid. Next. So advantages of using GnRH analogs in patients with endometriosis. Its advantages are that it's maximized during the time of greatest disease suppression. So it really brings down the estrogen level, and that is important. Must be used immediately before IVF and is associated with higher pregnancy rates and implantation rates. Patients with stage 3 and 4 endometriosis who are subjected to GnRH therapy of 6 months prior to their IVF cycle showed a 30% increase in pregnancy rates per cycle compared to those who had undergone just standard or controlled ovarian stimulation. Next slide, please. So the only thing is that surgery in endometriosis can become recurrent because it reduces your ovarian reserve and its recurrent rate, and also pleiotropic disorders can occur. Next slide. Surgery in severe endometriosis for infertility, it's uncertain whether surgery improves the fertility. Next. Next. Yeah. Surgical treatment of endometriosis associated infertility with AFS, ASRM, stage 1 and 2 endometriosis, operative laparoscopy, excision and ablation of the endometriotic lesion, including adhesive lysis, increases clinical pregnancy rate and ongoing pregnancy when compared to diagnostic laparoscopy only. It's grade A evidence. So suggests that stage 2 and 3, stage 1 and 2 endometriosis laparoscopic ablation of the endometrial implants has been associated with a small but significant improvement in the live birth rate, about 8.6%. Next slide. Yeah, endometriosis with IVF here in Banhart et al. Pregnancy rates is halved in women with endometriosis going through ART treatment. However, Harb says in 2013, detrimental effect of endometriosis on implantation and pregnancy rates. So we need to balance the beneficial and the harmful effects of surgery. Next. Next, please. So, impact of endometrioma surgery on IVF results, risks and benefits. So, if you remove, risks of removal of normal ovarian tissue is also possible, and the follicles that go with the endometrioma are surrounded by the fibrotic capsule. So, therefore, reduces AMH as well as the AFC. Ovarian endometriosis ablation, cyst wall cauterization, and vaporization of CO2 laser. The same thing happens, decreases of AFC and AMH. Next slide. So if you look at it, why endometriosis should not be operated before ART is the same thing, because no effect on total dose and duration of stimulation has been recorded. Next slide. Endometriosis not be again tells you the decreased number of oocytes retrieved and the embryos formed. Next slide. Again, no effect on implantation rate, clinical pregnancy rate, and live birth rate. Okay, next. So, surgery prior to ART in women with ovarian endometrioma, the X-ray development guideline development group says that grade A is in infertile women with endometrioma larger than 3 centimeters. There is no evidence that cystectomy prior to ART treatment to improve pregnancy rates as grade A evidence, and with the guideline development group in the women with endometrioma larger than 3 centimeters, the guideline group recommends that clinicians only to consider cystectomy prior to ART to improve endometriosis associated pain or accessibility to follicle. So it also recommends that clinicians counsel their patients with endometrioma, possibly that they may lose some of their ovary, and then go ahead and do the surgery. Next slide. So, which treatment to choose in IUI? Treatment with IUI improves fertility in minimal and mild endometriosis. Yes, their level evidence A, 1B. Threefold increase in live birth. IUI with controlled ovarian stimulation is effective, but the role of unstimulated IUI is uncertain. Intrauterine insemination and controlled ovarian stimulation within 7 months after surgical treatment. Clinical pregnancy rate, first cycle, and birth rate explained. Infertility equals to endometriosis. So that's the thing that we should be thinking of. That's as quickly as possible. Controlled ovarian stimulation with IUI gives you best results. IUI and controlled ovarian system versus expectant management. Certainly, cumulative live birth rate and fecundity rate certainly better with controlled ovarian stimulation with IUI. Next slide. So for IVF, IVF is the appropriate treatment if tubal function is compromised in presence of male factor infertility and or treatments have failed. So controlled ovarian stimulation for IVF and XC is equally effective with both DNRH antagonists and agonists in terms of implantation, pregnancy, clinical pregnancy rate, but controlled ovarian hyperstimulation with DNRH analogs may be preferred because of the availability of more M2 oocytes and embryos. Next. So indications for IVF and endometriosis would be diminished ovarian reserve, female more than 37, infertility duration or more than 5 years, failed controlled ovarian stimulation, IUI, recurrent endometrioma, bilateral endometrioma with adenomyosis, bilateral tubal factor, and male factor. Next, please. So endometriosis versus tubal infertility, you'll see that the odds ratio of 0.5 here. It just goes to show that endometriosis will worse than tubal factor. So if you're looking at IVF, it's better to have a tubal factor rather than an endometriosis, because in tubal factor, it's only a mechanical problem. With endometriosis, it's also a problem with the egg. Minimal and mild endometriosis versus no endometriosis, fertility, this thing is almost the same. Pregnancy outcomes in IVF based on indication. Endometriosis only live birth rate is about 45%. Endometriosis plus would be live birth rate is decreased to 33%. Next slide. So medically assisted reproduction in endometriosis in the infertile women. Endometriosis clinicians may perform IUI with controlled ovarian stimulation instead of expectant management, as it increases the live birth rate, and recommended use of ART in infertility associated with endometriosis, especially if tubal function is compromised. If there's a male factor infertility and or treatment have failed, definitely that could be used. Next. Okay, so this is where we're going to look at. These are some things which are just giving you. I'll go to the last few slides. Next slide, please. Medical therapy and before IVF, not required. Next. Okay, so in conclusion, efficacy and safety of IVF patients with severe endometriosis after long-term pituitary downregulation is IVF patients with severe endometriosis is a safe procedure. In patients treated with long-term pituitary downregulation, ongoing pregnancy rates are diminished after fresh embryo transfer. However, including cryopreserved embryos transfers, long-term pituitary downregulation has beneficial effect. The frozen transfers give better results. Next. It's the same thing that when frozen transfers give better results. Next. Agonist and antagonist protocols is the same thing. Agonist or antagonist protocols, similar results. Next. Hormonal treatment for endometriosis before IVF, long-term agonist therapy before in vitro fertilization for improving fertility outcomes has uncertain benefit. Next. How endometriosis affects oocyte quality. These are the ones that you need to do. Inflammatory cytokines, oxidative stress, and vascular dysfunction. Next slide. And for endometriosis and implantation, for long it was thought that endometriosis doesn't affect implantation, but endometriosis promotes progesterone resistance and estrogen dominance in utopic endometrium of women with endometriosis. And thus progesterone resistance is resulting in inadequate antagonism of estrogen action and increased inflammation, defective decidualization, leading to a non-receptive endometrium for embryo implantation. Next. These are all just to explain the same thing. Next slide. Next, same. Next. Do we freeze all in endometriosis? There's not enough evidence to suggest that you need to freeze all in a standard strategy. Next slide. Impact from this thing. Certainly it does have an impact on the ART outcome, but it's not as bad as we think. Frozen transfers give better results than fresh transfers. Next slide. Adverse pregnancy outcomes. Yes, early pregnancy loss, ectopic pregnancy, greater chances of DDM. Hypertensive disorders in pregnancy are known to be slightly higher with endometriosis. Next slide. So if you look at the miscarriage rate, then you look at even the follicular genesis. Sorry, just give me the slides, please. Can you put the slide back? Can you share the slides, please?
Next one.
Sana.
Not next.
It's not sharing.
How many slides?
I got 2 slides more.
Okay. Sana, your slides are not moving. Sana.
Last 2 slides are required.
Yeah. Just those take-home messages I want. There's a thank you slide and 2 slides.
I think you can sum up because probably she has lost it. Yeah.
No, last. That's all. No, just one slide before that. Before. The impact of endometrioma and its surgical treatment on the ovarian reserve and infertility still remains controversial. Damage may precede surgery. Endometrioma itself may cause negative effects on the surrounding tissue. Surgery for endometrioma must be performed carefully to limit the risk of damaging the ovary. To achieve this, we need experienced surgeons and appropriate technique. Medical therapy not effective in restoring fertility. Surgical therapy may be effective to restore fertility. Effect of IUI-COH not fully clear. IVF is effective. Next slide. This endometriosis per se is associated with decreased oocyte quality in IVF cycles. Recent data questions the merit of long-term agonist therapy compared to no pre-treatment to standard IVF in women with endometriosis. Antagonist or agonist protocols, similar reproductive outcomes. Currently not enough evidence to use freeze-all as a standard therapy, and in women with endometriosis, conceptions with or without IVF are associated with increased obstetric risks. Next, last slide. Thank you all very much.
Thank you, Dr. Kamini, for an excellent presentation and telling our attendees how to decide on the endometriosis, whether you have to go for surgery. You have given a lot of tips, and I believe there are a lot of questions, but we will be taking these at the end. So I invite Dr. Sudha Prasad to invite our next key opinion leader, who is again a doyen in the field of reproductive medicine, endoscopy. Dr. Sudha, please.
Thank you, Dr. Kuldeep. After hearing an excellent talk from Dr. Kamini Rao of the reproductive age group, again, another complex area is the adolescent group, because adolescent, when I was seeing through the register.
Dr. Sudha, Dr. Alka has to leave, so can you introduce Dr. Alka?
I see.
Yeah, Dr. Alka is next because she is having another program.
Where is she leaving on Sunday?
No, she is on another program after this. So Dr. Alka will be speaking first.
So the endometriosis is a very complex. Since morning we are hearing how to make the diagnosis and medically whether it can be treated or not treated. Finally, we can reach at the end when the woman is very much in agony, having pain, big endometrioma, then she really requires a surgical treatment. And you know very well Dr. Alka Kriplani, the past president of FOXI, and I know her since All India Institute when we were together at AIMS, Delhi. And I want to introduce her formally, Dr. Alka. She is the director and head of department of and ART at Paras Hospital, Gurgaon now. And she was ex-professor and head at All India Institute of Medical Sciences in Delhi. And she was heading so many societies, FOXI, JC, DGS, AOGD as a president. And she is going to talk on endoscopic treatment of endometriosis. So one thing comes in my mind, Dr. Alka, that all the listeners, all the viewers will like to know that how rectovaginal endometriosis best diagnosed, which is a very difficult, complex part of endometriosis. Patient will come with the pain and diagnosis will be very, very difficult in these patients. Again, another one, is it the better to do laparoscopy then laparotomy for it. How to tackle rectovaginal endometriosis? Please give tips and tricks to our listeners. How would the type and extent of bowel involvement alter your surgical technique? And what is the role of nerve-sparing surgery in deep endometriosis? Any role of medical therapy in rectovaginal endometriosis management? So please cover all these questions, and over to you, please, Dr. Alka. Please unmute yourself, Dr. Alka. Please unmute.
Hello.
Yeah.
Am I audible?
Yes.
Thank you so much, Dr. Sudha, for your kind words. And you rightly said in COVID times, where can I go? But the thing is, we have complicated our life further, and we are committed to so many webinars that we are busier than we were traveling.
I know. That is true.
So I have with Prakash Trivedi in the afternoon another webinar on complications and video presentations. So that is the reason. Thank you very much, Dr. Kuldeep, for accommodating me and breaking the queue for me. I am very thankful. But the thing is, at afternoon, I have to be there. So I have to be virtually there. First of all, I would like to thank IFS, President Sudha Prasad. And I would like to thank ICOG, Dr. Mandakini Parihar and Dr. Biniwale. And I would like to thank AOGD Mala Srivastav. Would like to thank Endometriosis Committee Chair, Dr. Asha Rao, and pardon me if I'm forgetting any important person. Most important, Kuldeep Jain. He has been communicating for long and really has worked very hard for this webinar to happen. Can I have my slides? So I will go to slide share. And this is my presentation. Dr. Kuldeep, you and endometriosis now are synonymous, you know. And you are really, first you were chairperson. This is in the middle of the presentation. How can I go up? Yeah, perfect. So the topic allotted to me was advanced endometriosis. And I'm very well aware it may not be of great concern to many infertility specialists, but I would like to emphasize on the practice points which we have learned along way of this disease. I bring you greetings from Paras Hospitals, Gurgaon, where I'm practicing presently. How much is the time, Dr. Kuldeep?
15 minutes.
Okay, so I think I'll skip on, and this is very important. All those who have been operating for decades endometriosis, including myself, have realized surgery may not be the ultimate solution because recurrence is a big issue, and we have to counsel our patients that once they are diagnosed with endometriosis, they have to live with the disease, and we can provide modifications. So avoiding repeated surgical procedures is our aim. And it is very important to decide when to operate, as majority of us are agreeing that quick surgeries, in olden days we were getting 3, 4, 5 laparoscopies, laparotomies, still we are getting patients like that. That is not the best way to manage endometriosis. So you have to intervene surgically only in specific indications, like when medical therapy fails, like when she's having very bad symptoms affecting quality of life, when you have to potentially exclude potential malignancy, and in selected women with infertility, and of course in deep endometriosis, which leads to very incapacitating symptoms and quality of life. So we have lots of surgeries, conservative, definitive. When we talk of infertility, definitely conservative surgery is the preferred choice. But many times, even in younger patients, you are forced to operate and do definite surgery because we all know the extent of disease and deep endometriosis may be the deciding factor. So Dr. Sudha posed few questions, and one was whether to open, whether to laparoscopic, whether to robotic. Once you have proficiency in the technique of endoscopy, because the way the scope enters and you see the pouch of Douglas first, and the magnification of scopy definitely makes the surgery simpler laparoscopically. And as we talk of robot is just a help in converting open to laparoscopic. Otherwise, for a trained endoscopic surgeon, robotic has no added advantage to my mind. Why surgery is a challenge in cases of advanced endometriosis? Because extensive dissection is necessary. Disease in majority of situation in the retroperitoneal area, so you have to acquaint yourself with the anatomy of retroperitoneum, a meticulous surgical technique, good knowledge of surgical anatomy which requires years of understanding, and multidisciplinary specialty, especially in private practice. You have to have availability of good colleagues, urologists, good anesthetists, because sometimes surgeries go so long, and good colorectal colleagues. And of course, advanced laparoscopic skills are required. Pre-op assessment, I will not deliberate in detail because Dr. Asha was very good with this assessment, history taking. Only taking when I'm dealing with deep endometriosis, important is that always take the history in previous surgeries, what level of surgeon and what all has been done. Suppose her ureter has been reimplanted. Suppose her bowel was adherent and there was injury. So the next person who is operating has to know all these details. Unfortunately, many times these patients do not have proper papers and it becomes an issue. You get a patient who has previous 5-6 surgeries. So you really want to know up to what extent dissection has been done, what all organs have been dealt with, and it is important for your surgical procedure planning. So examination, very, very important, especially for rectovaginal nodule and to rule out. So many times we see there is vaginal endometriosis on a good proper per speculum examination in proper light, and then your approach totally changes because that nodule needs to be excised. These patients often have very bad dyspareunia. When we talk of imaging, again it has been dealt in detail. So there are two very important investigations. One is availability of transvaginal ultrasound, but that is mostly observer dependent. We can't get the picture. So unless your ultrasonologist is very good and you can rely, because your surgery will depend, your outcome will depend. TVS is a very good modality, and majority of situations we depend on MRI. If you are ordering MRI, please tell them to have contrast, because you want to know the rectum, whether it is involved, how much rectal thickness is involved, whether it is very superficial, whether it is deep, and if you have doubt, we get colonoscopy done to know whether the nodule is traversing total through and through the rectal wall, because it is very important when you tailor treatment and surgery for the patient. So these are the do's and don'ts. When you want to rule out rectal endometriosis, tell her to keep her rectum empty with good purgatives. And then when you send her for MRI, tell MRI person what exactly you want to know. And with contrast, and a good MRI person with contrast tells you how deep is the deep invasive nodule. Bladder, ureter, the same way. So after taking history, especially previous surgeries, after investigating, especially good MRI films, then comes your preparation for surgery. This is very, very important, because once bowel is involved, you have to tell you may end up in diverting colostomy, and for that, it's to my mind, it's the most important consent and counseling, because patients, the moment they listen to that there may be a stoma and the bowel may be diverted, They just run away because everybody fears that. So taking a proper consent, involving multidisciplinary team, showing the patient to your colorectal colleague beforehand or your urologist if it is bladder, because you may need ureter implantation and you may need stenting beforehand. So one has to really plan these surgeries beforehand. And the most important part of the talk, where I love to show my work, my videos and surgical steps. So I would just like to discuss in the next 5 minutes the surgical do's and don'ts. If you want surgery to be simple, it starts a day before. You think, you plan your procedure, you have to, surgery has to be contemplated in mind tomorrow what all you are going to get. And proper positioning, good anesthesia, all these things are very important for good final outcome. Then, of course, you have to beforehand diagnose and identify these lesions. You may not think that the pelvis is looking so bad, and once you open retroperitoneum, you see so much of fibrosis which distorts the anatomy, especially ureters are, puckered. So you have to open the retroperitoneum and have idea of exact extent of the disease. And this is like tip of the iceberg sometimes, that you don't see the lesion, and once you go deep, you see a big lesion there. So what are the principles of treating deep endometriosis? Deep endometriosis means bowel, bladder, retroperitoneum, uterosacrals, all these basically retroperitoneal structures involved. So principle of surgery is go from the easy area where there are less adhesions or no adhesions to the more severely affected area. And it is now like mathematics after doing so many cases, that first of all, when you enter with the scope, you go to the line of torus and you dissect the sigmoid, because if you separate the sigmoid, first thing you see is the left ureter and infundibulopelvic ligament. And then in surgery, you have to drain those endometriomas in the ovary because they occupy so much of space. And many people believe in diverting, in stitching the ovary to anterior abdominal wall. If you have a good team, they can do traction. So these are the options. So keep ovary away from your field and then start dissecting from the clean area to the affected area. First thing from left side, mobilize the sigmoid. Second step of the surgery is you have to, it's very easy, colleagues, to make a good team, have colleagues, and somebody shows you properly the manipulator. 3 manipulators I require here: uterine manipulator, a sponge holder in the vagina, posterior fornix, and you may need in between your surgery to delineate rectum, a rectal probe or a sponge on a holder, so that during your surgery these organs can so nicely be delineated that chances of entering into a rectum inadvertently are less, and your dissection becomes easier after identifying the anatomy. So optimize exposure by all these manipulators. First step is to dissect the sigmoid. Second step is to do ovariolysis, and third is to clean and dissect both the ureters so enemy is in front of your eyes. Once you have mobilized both the ureters, one, it will relieve her hydroureter, and second, you are unlikely to injure ureter. As I said, in these cases, they are very badly, anatomy is distorted. Mostly they are towards medial side. They may be joined to uterosacrals. So once you have dissected the ureters, the injury to ureter risk is also very less. And then the fourth step is go to open the pararectal area. As we teach nowadays again and again that hysterectomy in a previous cesarean is so much easier because the Dr. Shirodkar techniques go down the scar and then come up. And in rectal endometriosis, again apply same principles. Believe me, it will be so much easier. So open the pararectal area, go below the rectal nodule, see the clean area in the vagina and come up, and you will see there is a place on the cervix where the rectum is stuck. So you isolate it all around and then dissect it without energy source. So these are the steps, 5 steps, and in between aqua dissection or putting vasopressin on the posterior surface of uterus, it contracts the uterus, it reduces vascularity, and adiolysis may become easier. And the most important point, colleagues, knowing the spaces in the pelvis. Paravesical, pararectal, there are different names to spaces. When we do deep endometriosis, 2 spaces are of utmost importance to me. One is Okayabashi space and one is lateral Letsko. There is nothing much in the names. One is in between uterosacral and ureter. All the nerves of the pelvis are traversing in that area, the inferior hypogastric plexus. And second plane is between the rectum and the uterosacral, where if you dissect in the correct place, you will go immediately below the rectum in non-adherent area. So these are the steps of surgery, and these are the other endometriosis is reported even in the bowel, urinary tract, even up to the diaphragm. So it can be anywhere. So please have a look all around in the abdomen, because many times there are surprises and you want to excise all visible lesion. That is the principle. And as I said, rectovaginal space, learning to dissect is very, very important. And once you have finished the procedure, you must check for the rectal integrity. And these are the ways. Either you fill up the saline in the pelvis and tell your assistant to push air through the anus, and if there are bubbles coming. So checking the rectal integrity is also very important. I won't go into ureteric involvement, but it is of 2 types, intrinsic, extrinsic. Mostly we get extrinsic, and if you do nice dissection and remove fibrosis, hydronephrosis, hydroureter goes away. But if you see ureter is involved, then you have to remove the segment. As Dr. Kuldeep was very particular about rectovaginal nodule, so in 5 minutes I'll be discussing the principle how we are tackling nowadays. So diagnosis is very important. Rectovaginal nodule can just be up to the serosa of the rectum. Rectovaginal nodule can be involving muscularies of the rectum, and a rectovaginal nodule in the most severe situation can be perforating the mucosa and protruding into the bowel, and that is a situation where patient presents with blood through the stool. So proper history taking is very important. There are different techniques we use now in these three situations. So what do we do? If it is very superficial, in majority of situations we do is shaving of the nodule from the rectal wall. And you always take a consent if it is deeper into muscularies, and you open the bowel, prepare the bowel very nicely and suture it if it opens at some place. And second is discoid excision. If muscularies of the rectum is involved, then we excise the segment which is involved with the endometrioma with a fresh disease-free margin, and then suture the rectum. Rectum is always sutured transversely. The problem occurs when this nodule is in the lower third of rectum. That is an area where rectum is, mobilization is difficult, and we all know any area where you suture and mobilization cannot be done properly, they are high risk for fistula formation. In those situations, we call our colorectal colleagues, or if it is through and through lesion, so then you may require end-to-end anastomosis and resection. And if it is a very severe situation, then diverting colostomy for 6 to 8 weeks. So this is the principle which we follow in managing. And mostly nowadays we try and do shaving. You need not be very, very aggressive on the rectum, and majority of time patient symptoms go away. And if you feel that the through and through muscle is gone, then nowadays more and more people, including myself, are going for discoid and removing the lesion and suturing the rectum, unless the big area of the rectum is involved, if the nodule is more than 3 centimeters, or if it is in the lower third of the anal verge. In those situations, resection anastomosis is recommended, because these cases are high risk for stenosis and fistula formation. So this is one of the cases we recently operated. See, it takes time to learn correct anatomy, and if you can do adiolysis through correct planes, so all the vital structures, always these are young patients, so do nice tubal division of adhesions, and this is the area which gynecologists really are fearing because of the fear of rectal injury. But see, near the rectum we don't use cautery sources, we use simple scissors, and see how nicely the pelvic planes are coming up, and it is all, this is the pararectal, in between rectum and laterally uterosacral. Open this space, there is nothing there, and if you can see the virgin area where there is no endometriosis, and then come up. So see, at the end you have cleared nicely the rectum, and these are the nerves, inferior epigastric plexus. Good olden times we used to recommend, even we used to do these surgeries, hypogastric, cutting off so that dyspareunia is taken care. This is not a current concept. What happens if you destroy pelvic nerves? The patient will end up in bladder and bowel dysfunction, very bad constipation. So nowadays we are more and more conscious, and we try to preserve their nerve supply. And this is what, take as thin as possible, as Dr. Kamini was emphasizing, that ovarian reserve is a big issue. So I believe in reconstructing, we don't believe in putting cautery. You reconstruct nicely, there will not be any raw area, and you won't need to put any cautery. So this is what, conserving the ovarian tissue is of prime importance for a laparoscopic surgeon, so that her ovarian reserve is preserved as far as possible. All these grade 3, 4 endometriomas, we endoscopists believe that majority of time, if ovarian reserve is good, you can give good pregnancy rates without ART procedures. So this is what, again, this is the case I did last week only, a huge rectovaginal nodule. So this is the nodule, and it was 13 centimeter above the anal verge, and we have talked to colorectal surgeons, but once you have sufficient experience and you have a colorectal surgeon on call, we do it ourselves. So this is what is resection of the patient, had very, very bad symptoms of dysphagia and incapacitating pelvic pain. So this is what, and the endometriosis was on many places on the bowel. So pains, this is at the end. You check for the bowel integrity, always put a drain, and be careful that rectal integrity, and somebody is pushing the dye from below. This is, the ureters are always mobilized till whole length so that you safely dissect the area. So this is what, again, restoring the anatomy in the pouch of Douglas, because she had bad dyspareunia. So you have to be careful about restoring anatomy, otherwise her deep dyspareunia may not go away. So these are the planes in the pelvis. In between uterosacral and rectum is the pararectal, where I am dissecting now. In between uterosacral and ureter are the nerves, inferior epigastric plexus. Be careful, you may have to resect part of uterosacral ligament to give her a cure and to remove all the fibrosis as per. Somebody is showing me so nicely from below a probe in the rectum, and you see this is the area where was the nodule, and the nice lovely supple rectal wall is seen here. So end result should be remove the disease, remove majority or all the fibrosis as far as possible. Urinary tract, I think I'll exhaust with my time. Otherwise, we have two ways. One is always fill up the bladder partially and then give incision, and always do pre-cystoscopy to check what is the distance of the nodules from the ureter opening, because the bladder is a very forgiving organ, except that if you injure ureter while taking out a big lesion. Last week I got a patient who has 7 centimeter lesion in the bladder, so I will be getting stenting of the ureters and then doing complete job and partially fill the bladder and then incise the nodule. So you will have all the nice idea, map the lesion and then resect. Another way, if it is not a very big lesion, is like we used to do TCRE with a good urologist. They do transvesical resection of the lesion and many of our patients are doing well in long-term follow-up, and once they had symptoms of hematuria, they are completely cured of it. So these are the two ways, either complete resection or resecting the nodule transvesically. And bladder is a forgiving organ. You don't fear much, except you have to check. Uretral and endometriosis, again, if it is extrinsic, you can dissect out without damaging the mesentery. If it is intrinsic, means wall of the ureter is involved, then you have to remove the segment of the ureter, and this is best done laparoscopically. Even implantation, if it is very near to bladder, implantation. If it is little far, then you do swasage. If it is very far, worry flap, for which we take help of our urology colleagues. This I have very, very good experience over the years. Lots of colleagues keep referring cases of abdominal wall endometriosis. So this doesn't respond to drugs, medical therapy, because that area is fibrosed. So whatever drugs you give, they don't penetrate, they don't reach that area of the nodule. And this is a very rewarding surgery, colleagues. You do complete excision of the nodule and she is free of her pain. So diaphragm, I never saw, but I have heard that diaphragmatic nodules are this is a known entity, and it leads to very bad symptoms. Often you will find a frozen pelvis, and as I discussed with you, it is like mathematics, how to clear a frozen pelvis. First, go at the brim, go from the clean area, go to the area where there is dense fibrosis. At the last, release both ovaries, release both tubes, because they have to function. And after that, open the pelvic spaces. Learn to work in the retroperitoneum. Otherwise, you cannot do justice to deep endometriosis and resect majority of the fibrosis to give her relief. And just to summarize, adequate assessment and counseling. I would like to give one statement. If you open a patient, please send deep endometriosis to people who are regularly doing and who have availability to multidisciplinary team approach. Because once you do a surgery, you dissect it, then you abandon the surgery. It becomes very difficult for the person next to go in that area, especially retroperitoneum, especially if the ureter is injured, especially if the bowel is repaired. Then for the next person to go in that area and do justice becomes really difficult. So these cases should be assessed properly and should be sent to the level 5 facility, where they have all the facilities to do full surgery in one go, because you get patients where they have 3, 4, 5 surgeries and then they land up with us. So it is very important. Communication, counseling is very, very important. Multidisciplinary team approach and availability of a perfect team is very important. A team approach, your team, because once you are doing these cases, you have to have a familiar team to do justice with the surgery. Appropriate energy source. When you are near rectum, use scissors, because energy source at that time may not, but later she will end up in your routine mobilization and good adiolysis, learning all these surgeries and taking proper training. Systematic identification. Expose ureters first if you want to avoid injury. And remember, in deep endometriosis, anatomy of ureters may be very badly altered. Try to preserve nerves. As I showed you in that video, they are between uterosacrals and ureter, and you have to learn the path of the nerves. Try to do nerve sparing surgery, because for bowel and bladder function, it is very important. Limit extent of bowel and bladder dissection. And competent laparoscopic suturing skills is also a key to success. So nowadays, so much of advancement is occurring. How? Because many times you may not even be able to diagnose the exact extent even during laparoscopy. So now they have all these, they are not available everywhere. But the best way we are doing it, open the retroperitoneal space and look for the lesion. So these are the narrow bending, all these imaging techniques. In future, they will make our diagnosis. 3D laparoscopy helps, especially when you do difficult decision low down. And these deep endometriosis, one one question remains unanswered. Dr. Sudha asked me, what is the medical role? Yes, there is medical role. We had a long data, we have published also, putting LNG IUD. But then fertility and LNG IUD cannot go together. If your patient has given up hope, or she doesn't want to become pregnant, or she has bad symptoms of bowel and bladder endometriosis, LNG IUD has shown good results in controlling pain of deep endometriosis. But what practically we have seen, you start her on Dynogest, you start her on drugs, you give her GnRH, you give LNG IUD. Ultimately, they'll end up in surgery. It is a matter of buying time, but buying time is also very important, especially when fertility is an issue. And in these times when people are going late for fertility, I think that is also the reason that we are getting so many endometriosis patients and so many deep endometriosis and so many dilemmas, whether to operate, do definite surgery, or send her to IVF colleagues. And it was an excellent lecture by Dr. Kamini that you first take out ova, make her embryos, and then you may go for surgery. It is also a very good option. But for us, for me, patients come as a last resort after many surgeries, after many failed IVFs, and usually they'll end up in definite surgery with this deep endometriosis. And rectovaginal endometriosis is becoming so much common. We are getting so many cases, and we are learning, we are still learning how much is ideal, and you have to have balance. You cannot be very, very extensive, you cannot be very timid, and after the surgery, if fertility is not an issue, putting your patient on suppressive therapy is a very good idea for long-term recurrence-free survival of your patient. Thank you very much for your patient hearing.
Thank you, Dr. Alka, for the excellent overview. You said very rightly, anatomy is distorted in deep endometriosis, and if you really think, then only you can diagnose. And the person who has the facility of multidisciplinary assistance only should be operating these kind of patient. Otherwise, the patient will go in difficult time because she has already gone to many other doctors. Thank you very much for your time and good.
Thank you, colleagues. Thank you, Dr. Sudha. Thank you, Kuldeep, and thank you all the colleagues, all the societies. I can see Mala also here for this opportunity, and I'm very sorry that I had to barge in, but you see, otherwise I will not be able to report to the next webinar with Prakash Trivedi.
Thank you. Thank you, Dr. Alka. I will just like to inform you that you were being heard by more than 550 people.
Oh, thank you. It is Kuldeep because of your work.
Thank you so much for joining. We would have loved to have you in the question answer session, but I know you are too busy. So thank you again for joining in. Thanks, Dr. Alka. Dr. Sudha, you can continue, please.
So after hearing the reproductive age group and the surgical management from Dr. Alka in a very elaborate manner, so we reach to the adolescents, which is the another age group which is having a very complexity when they land up for endometriosis, because they always delay in the presentation, and it is very difficult for bring the younger child, the less than 14-15 years old, to come to gynecology, unless otherwise they will have the day-to-day problem, not going to school, having deep pelvic pain, and so many problems are there with the adolescent, which is absolutely different from the reproductive woman. So I will present Dr. Sanjeeva Reddy to you, who is another big academician from the South, who is a professor and head of reproductive medicine and surgery at Ramachandran Institute of Higher Education and Research, Chennai. And he has the first super specialty course he has started in Obs Gynae, MCH Reproductive Medicine and the Surgery in India. and he has a special awardee. He is a special awardee of B.C. Rai National Award in 2015 as eminent medical teacher, and he is a founder secretary of Tamil Nadu and Pondicherry chapter of ISAR. So you are going to cover the endometriosis in adolescent, Dr. Sanjeeva, but I want to know that how you manage this endometriosis, and I have few questions for you, and I hope that you will cover all these, because this is a very complex topic, very complex when the patient, the child comes to you. Then I would like to know from you that what is the clinical profile of adolescent with endometriosis, because it is totally different. If you really think, then only you can reach to diagnosis. Is endometriosis in adolescent limited to early stage disease? And the third one, I would like to know that does hormonal suppression prevent the progression of endometriosis in adolescent? And my listeners are having the question in their mind that what are the challenges in diagnosis and treatment of adolescent endometriosis when the such kind of child comes to them. So please, over to you, Dr. Sanjeeva, please carry on. And time limit is 15 minutes. I know it is very small time, but try to be in this period only.
Can you ask them to allow me to share my screen?
Sure. Please share, Sana.
Okay. Thank you, madam, for your kind introduction. At the outset, I would like to thank Dr. Kuldeep Jain, good friend of mine for many years, for inviting me to share some of my thoughts with you all, and also including me in the elite group of speakers. Today, I'm going to speak on adolescent endometriosis. How do I manage? The diagnosis and treatment of endometriosis in adolescents poses unique challenges. Adolescents are more likely to present with non-cyclic pelvic pain. Endometriotic lesions visualize different appearance from those seen in adults. Both factors contribute to the delay in diagnosis and the resulting delay in treatment. So madam asked me to tell about what is the clinical profile of adolescents with endometriosis. You see, the prevalence of endometriosis in general population of adult women, it is 10%. If that particular woman is having chronic pelvic pain, it will be 80% of times it is due to endometriosis. In adolescents with some symptoms, if they are subjected to laparoscopy, 62% of patients, they will have endometriosis. And those adolescents with chronic pelvic pain, but resistant to usual treatments like OCPs or NSAIDs, there if you do the laparoscopy, 75% of adolescents will have endometriosis. The patients with severe dysmenorrhea with chronic pelvic pain, but they are getting some relief with tablets, they are not resistant to treatment. If you do laparoscopy here, 49% of patients will have endometriosis. Then what are the clinical profile of these things? The age will be varying from 10 to 21 years. The average is around 17 years. In 64% of patients will have dysmenorrhea, 44% of patients will have menorrhagia, and 60% will have abnormal uterine bleeding or irregular uterine bleeding. 56% will have, apart from these pains, they will have GI symptoms also. And 52% genitourinary symptoms. That means in adolescents, whatever type of symptoms patient presents to us, we should first think of endometriosis. And what are the risk factors for development of adolescent endometriosis? If the girl gets menarche earlier, this patient is more prone for, and dysmenorrhea is present from the beginning, and also secondary dysmenorrhea, there's more prone for developing adolescent endometriosis. When there is a history of asthma or family history of endometriosis in a first degree relative, or there is congenital malformations of genital tracts, these patients are more prone for developing endometriosis. Second question she asked is endometriosis in adolescents limited to early stage disease? There is no correlation between the symptom and the stage of the disease. Early reports suggested that endometriosis in adolescents consisted of predominantly early stage disease without the presence of endometriosis. But recently, however, several authors have reported severe, that is stage 3, stage 4 endometriosis in adolescents. If you see here in one study in 2017, the stage 1 is around 45%, stage 2 36%, stage 3 around 15%, and stage 4 up to 4%. That means all stages will be there in adolescents also, not only early stages. Next, third question he was asking me is, does hormonal suppression prevent the progression of endometriosis in adults? So the key to the treatment of endometriosis in adolescents is not only the control of pain, but also the prevention of disease progression. There is currently no consensus about the routine use of hormonal suppression after surgical diagnosis and treatment of endometriosis. This issue continues to be debated in the literature. There remains an urgent need for randomized controlled trials evaluating the efficacy of various hypoestrogenic agents as well as progesterone agents in the prevention of disease progression and the subsequent development of long-term sequelae in adolescents with endometriosis. The third question she was asking, fourth question, the challenges in diagnosis and treatment of adolescent endometriosis. We'll see. As usually, for any disease, we should take thorough history, detailed examination, and pelvic ultrasound. Here, one problem for us is the patient is not sexually active, we cannot do the transvaginal ultrasound because it gives better picture than the transabdominal ultrasound. Here, these patients we can subject only transabdominal, and also the superficial peritoneal endometriosis we cannot diagnose with ultrasound. Only deep like the rectosigmoid endometriosis sometimes we can make out. If needed, these patients we can subject for MRI. In addition, endometrial biopsy, biochemical markers, and finally the gold standard is the laparoscopy for the final diagnosis of the endometriosis. We'll see each one separately. Role of endometrial biopsy. Endometrial biopsy, if the patient is sexually active, then only we can take, otherwise we cannot take. But endometrial biopsy with assessment of the amount of neural fibrous has been reported to be a successful approach. With the immunohistochemical analysis of nerve fibers was detected with a specificity of 83% and sensitivity of 98%, positive predictive value of 91%, and negative predictive value of 96%. So this also we can try. What are the biochemical markers that will help us to diagnose non-invasively? CA125, CA19.9, ICAM1, and IL-6 together with follistatin and urocortin have proven to be the most reliable markers for endometriosis diagnosis. CA125, you have seen in all inflammatory conditions, it will be increased, takes a better diagnostic significance. Instead of diagnosing, for follow-up of the treated patients, surgically treated previously, these patients, if you go into follow-up, you can use the CA125, it will help. And CA19.19, a specific marker for the diagnosis of pancreatic cancers, but it also will be increased in benign conditions such as diseases of the biliary tract and endometriosis. ICAM1 is a member of the immunoglobulin superfamily and is involved in immune and inflammatory response. In endometriosis, greater amounts of ICAM1 are released by the endometriosis implants and found to be significantly higher serum concentration compared with controls. And also, it will be more in case of deep endometriosis than the superficial endometriosis like peritoneal endometriosis. And urocortin and follistatin. Urocortin belongs to the family of corticotropin releasing factor, which is involved in the modulation of the immune system and inflammation. Higher concentration of urocortin found in 80 to 88% of cases of endometrioma with a specificity of up to 90%. Follistatin, an active A binding protein, have greater tissue expression of follistatin in the case of endometriosis, so that this also we can use. Follistatin shows a sensitivity of 92% and specificity of 96%, so that is useful. Finally, we have the gold standard laparoscopy and confirmed by biopsy. In TJs, but one thing we have to keep in mind is Always ask the gynecologist to do, not the general surgeons or your husbands, even if it is very good laparoscopists, because the appearance will be different. If you take in the adolescent, it will be just red or no color, white. It would the usual thing, textbook description of like block or powder burn things, other things won't be there. That's why we should be very careful to take the biopsy and confirm. What are the management options? The goals of treatment for adolescents with endometriosis are symptom control, prevention of disease progression, preservation of fertility. Medical and surgical options are available for the management of endometriosis. Most experts advocate prolonged medical therapy following laparoscopic diagnosis and the excision of endometriosis lesions. The medical treatment is combined oral contraceptives. These are typically the first line of therapy in adolescents. This therapy is only suppressive, not curative. We have to counsel the patient. Symptom recurrence was common after stopping therapy after 6 months. Considering present evidence, the Cochrane database concluded that information regarding the long-term benefits of COC in the treatment of endometriosis is insufficient. Next comes to progestins. Medroxyprogesterone acetate oral form 20 to 30 milligrams daily, or if you are giving Difopam, it is 150 milligrams every 3 months once. 70 to 80% of patients show improvement in pain symptoms. But you should be very careful. Long-term usage of progestin therapy impair bone mineralization secondary to the hypoestrogenic environment induced by progestins. Progestin therapy is commonly associated with side effects. Apart from bone mineral deficiency, they will gain weight, there will be bloating sensation and mood changes and irregular bleeding. So when you're counseling the patient before starting itself, you should explain all these conditions. Next is the role of GnRH agonist. Treatment with GnRH agonists have been found to be extremely effective in alleviating particularly pain with endometriosis. The Cochrane group reviewed the efficacy of GnRH agonist versus the OCP in the treatment of endometriosis and concluded that GnRH agonist was more effective than OCPs taken in the conventional manner. Next is how you will give. Leuprolide acetate can be given as a 3.75 milligrams injection every 4 weeks, or there is a Difo preparation is available 11.25 milligrams once in 3 months. As with long-term progestin therapy, the problem is here also there will be bone mineralization will be affected. The use of GnRH alone is generally limited to patients more than 16 years of age. Before that you should not give, and for a period of 6 months. Next is the role of add-back therapy. If you want to continue more than 6 months with the GnRH agonist, it will produce all the problems, so that the add-back therapy was developed. Patients with severe symptoms and those respond well to GnRH agonist may benefit from continuing the medication for longer than the recommended 6 months. In adolescents, the effect on bone mass is particularly concerning, as most of the physiological increase in bone mass and density occurs during puberty. To protect bone demineralization and to reduce the side effects of pseudomenopause, hormonal add-back options are recommended. These include norethindrone acetate 5 milligrams daily and combined conjugated estrogen and medroxyprogesterone acetate 0.625 milligrams of conjugated estrogen and medroxyprogesterone 2.5 milligrams daily can be given. With both these regimens, the therapeutic effect of GnRH agonist is not diminished, but the side effects will be minimized. So experts recommend initiation of GnRH agonist always in combination with the add-back therapy. Just instead of giving only GnRH agonist for 6 months, then adding. So from the beginning, if you give, so you can preserve the bone mineral density. BMI monitoring at baseline and every 2 years for patients on long-term GnRH agonist plus add-back therapy is advised. Patients should also take adequate calcium and vitamin D supplementation to minimize the effects of bone demineralization. Next is the gold standard is surgical treatment of laparoscopy. Laparoscopy is prepared over laparotomy in adolescent. The goal of surgical treatment is to remove visible areas of endometriosis and restore normal anatomy by lysis of adhesions. Surgery has been shown to be effective in improving endometriosis symptoms. Reported improvement rates ranges from 38 to 100%. Various techniques are used, including laser vaporization, unipolar or bipolar coagulation, and endocoagulation. No one technique has been shown to be superior to any other. So whichever is available with you, you can use. Symptoms generally return in the majority of patients after 1 year without further treatment. These patients need to be put on long-term suppressive medical therapy as described above. So next is finally the role of Dynagast in adolescents. There are very few papers. 2 papers it has come. Dynagast 2 milligrams daily in the treatment of adolescents with clinically suspected endometriosis. So VISAN is study to assess safety of in adolescents. Here the conclusion of the study is the treatment of endometriosis in adolescents with 2 milligram Dynagast once daily for 52 weeks was associated with a decrease in lumbar spine BMD followed by partial recovery after treatment discontinuation. Because bone accretion is critical during adolescence, the physicians would need to weigh the benefits of Dynagast 2 milligrams against potential risks in individual adolescent patients, as well as take into account any significant risk factors for osteoporosis. If this is there, we should be decide whether the benefits are more than the drawbacks. The efficacy of Dynagast in relieving endometriosis associated with symptoms and signs of the profile of common adverse effects were comparable with those in adult population. Here the symptoms are patient will get very good relief, but you should be worrying about the bone demineralization. Next is another latest paper. Here long-term medical management of endometriosis with Dynagast and with a gonadotropin releasing hormone and also add-back therapy they have given. They compared with the gonadotropin GnRH agonist and along with the Dynagast and add-back therapy, and we'll see what is the effect. The conclusion of this study is both Dynagast and GnRH agonist with hormone add-back therapy seems to be equally effective for long term. So that means GnRH agonist and add-back therapy, and separate another group is Dynagast with add-back therapy. So they are giving equal results. There is insufficient evidence to report the superiority of one therapy over the other. So you can decide. Symptom severity, disease location, and reproductive plans play a key role in treatment selection. It is important to consider the patient preference in the treatment approach and to provide appropriate counseling on the risks, side effects, and the cost. So in summary of the treatment, history, physical examination, you can use the ultrasound if you needed MRI, and pain DNA also you can use. In this patient, you can go for the cyclical hormone therapy and also NSAIDs. If the patient is not responding, then you can give the empiric GnRH agonist if the patient is above 16 to 18 years. If improved diagnosis is confirmed that it is only endometriosis. When you do the laparoscopy and biopsy, and we'll be most of the time, just we can go for the ablative resection or laser endometriosis. If there is no signs of endometriosis, then we have to investigate this patient for other things like gastrointestinal, urological evaluation for the pain management. If the gross histology proved that it is only endometriosis, depending upon the age of the patient, we can go for the treatment. If the patient age is less than 16 years, you can continue the non-cyclical hormone therapy. If the symptoms persist, then we have to go for the GnRH agonist and add-back therapy. If the patient age is more than 16 years, you can directly go for the GnRH agonist therapy. And after that, non-cyclical hormone therapy, you can continue. If there is no pain, you can continue the hormone therapy. If there is a continuous pain, then you have to go for the laparoscopy with the resection of the endometriosis and pain management services, or you can go for the Dynagast and add-back therapy also. Thank you.
Thank you, Dr. Sanjeeva. I know it's a very, very difficult part to treat these adolescents when they come on the point of endometriosis, because the symptom is very vague. You have to reach one by one, stepwise. You have to reach on diagnosis and you have to give accordingly the treatment. Certainly one cannot jump for the laparoscopy or dynogest. You have given a very good, you have shown the very good paper that dynogest also causes the decrease in BMD. So one has to be very, very careful, because it looks very easy to give medical therapy to these adolescents, these small girls. But one has to be very careful about all these things. So please stay connected. We will have the question and answer.
Madam, I have to leave. I'm in the middle of another webinar. I'm just leaving, madam.
Yeah, thank you, Doctor. Thank you, Dr. Sanjeeva, for your wonderful, excellent lecture. And I thank you for connecting me, though you were busy in another webinar. So thank you again. If there are any questions, I think we will.
You can take, no problem.
Yeah. So we will be continuing. And now this is my pleasure. Yeah, this is my pleasure to introduce another stalwart who is actually the institution is in himself. This is none other than my dear friend Rishikesh Pai. Rishikesh, I really apologize. I really apologize for you to be shifting because of the problems that few of our star speakers, they were having other assignments. So I hope you.
There is no problem, Sudhi. Kuldeep, there is no problem.
I also, Dr. in person, I wanted to congratulate you for the President-elect Foxy, because we have not seen each other.
Yeah, he is.
We are all here. We are all here waiting for Rishikesh's lecture.
So, I would like to first of all thank Kuldeep and wish him all the best for the future. He's going to go for an election, we know that. And, I would like to talk about endometriosis and ERT thanks to Dr. Sudha Prasad, my friend, Dr. Mandakini Meg, Parag Biniwale, and a lot of others, Kamini Rao, Alka, Kriplani, Bhaskar, Asha, Dr. Sanjeev just left, Ramani Devi, of course, is the doyen of endometriosis. So, there are a lot of causes of infertility. I'll not go through it. You can hear me well. My sound is good.
Not seeing Rishikesh's picture.
Pardon?
Maybe.
Rishikesh, before you start.
His face, I can see now. Yes.
Before you start. Yes, I can hear you.
Yeah.
Yes, I can also hear you.
Forget the picture. You can see my slide, no?
No, I can see you now.
Achha, Dr. Rishikesh.
Yes.
Before you start, I know you will take care of this endometriosis in ART, for the ART when the patient comes as an infertility to you. But there are the questions that what is your mantra? We want to know to optimize good pregnancy rates in endometriotic patients. And what is your favorite protocol in endometriosis? I believe everybody, including me, also want to learn this from you. And do you prefer removing endometrioma before IVF, or do you prefer a fresh transfer or frozen transfer in endometriosis patient? Please try to give in your talk all these questions. Thank you. Over to you, please.
Yes, madam. So, if you look at the various causes of infertility in endometriosis, you have ovulatory dysfunction, immunological alterations, peritoneal factors. But the most important cause as far as IVF is concerned is poor oocyte quality and embryo quality. And the implantation also, there is an endometrial dysfunction, especially there is a impaired AVB3 integrin, which is impaired in the endometriosis. And there are a lot of issues that contribute to a bad outcome of fertility. There may be in the pelvic cavity, there may be macrophages, there may be negative effect on follicles and oocytes or create hostile environment for fertilization. In addition, endometriotic lesions produce different cytokines such as interleukin 1 beta, IL-6, IL-8, tumor necrosis factor, and can lead to implantation failure and early spontaneous abortions even in a IVF cycle. And there is this new thing that has come for ovarian reserve, and this was a paper by Isil in 2018 where he and he did AMH and AFC every 6 months, and he showed a drop of nearly 26%, and the AFC count dropped from 10 to 8. So women with endometriosis experience a progressive decline in AMH levels as compared to from 3 guidelines: the ASRM guideline of 2012, it's called normally the Practice Committee guideline; the HD GDG guidelines that are 2014, where there were 22 questions and 83 recommendations were done; and the FOXY GCPR guideline, which was when I was Secretary General, Alka Kriplani was the president, and Dr. Ramani Devi had done this guideline, which is not nearly 80% of it is based on the GDG HD guideline. So I would like to make you understand the guideline. Nowadays don't like to give any papers, because when you quote from the guideline, they have already analyzed the entire literature. So what I'm telling you is the analysis and summary of the entire literature. So if you look at the endometriosis, you have to cover it as adolescent endometriosis patients want to retain fertility for the future, and then in the infertility patients you may have mild endometriosis, endometrioma, moderate, severe, and then we will talk about recurrent endometrioma. So if you look at the committee report of 2012, I'll first go through the committee recommendation. The endometriosis is common chronic disease. Although most women typically present with pelvic pain, infertility, or an adnexal mass. Female age, duration of infertility, pelvic pain, and stage of endometriosis should be considered when formulating a management plan. The benefit of laparoscopic treatment of minimal or mild endometriosis is sufficient to recommend laparoscopy. Laparoscopy is recommended to increase the likelihood of pregnancy. Laparoscopy can be done if there is abnormal ultrasound finding or the patient is symptomatic. The patient may have pain, dysmenorrhea, etc., or as an incidental finding. So you put a scope in and you may find incidentally endometriosis. And when laparoscopy is performed for stage 1 and 2 stage endometriosis or for other indications, the surgeon should consider ablation and excision and biopsy. Excision biopsy is very important to establish histopathology diagnosis of endometriosis. There is insufficient evidence to determine if controlled ovarian stimulation with IUI is more successful after endometriosis is diagnosed and treated compared to, you can just leave it alone, and we don't have studies that are comparing. Just if you leave the patient alone, don't do treatment for asymptomatic endometriosis stage 1, 2, whether the pregnancy outcome will be the same if you compare it with treating them. In younger women under the age of 35 with stage 1, 2 endometriosis, associated infertility, expectant management, or IUI can be considered as first line of therapy. For women with stage 1 or 2, 35 years or age or older, more aggressive treatments such as IUI or IVF may be considered. So more than 35 is the differentiating factor. Less than 35, you can go for a conservative management, that means do nothing. Just try to make them pregnant on their own naturally, or an IUI, or you can go, if that fails, for IVF. In more than 35, you can go for IUI directly, and if that fails, go for IVF. In women with stage 3 or 4 endometriosis associated infertility, as the stage increases, conservative surgical therapy with laparoscopy or laparotomy may be beneficial. Surgical management of an endometrioma should include resection of the ablation rather than drainage. And resection is preferred. We want to resect because if you don't take out the entire capsule, you may have a recurrence. Ovarian reserve testing should be done. So before you do surgery, you must do AMH levels, AFC count to see what is the reserve. In case of poor ovarian reserve, fertility preservation in the form of oocyte freezing or ovarian tissue freezing may be offered. On table, you can take out the ovarian cortex, and in our group, we do also ovarian tissue freezing for these patients, especially in those patients who want to retain their fertility potential, but who are not planning. So many of the patients may be in the fertile age group, they may be married, but they may don't want pregnancy that early. So they may say that, doctor, please, I don't want a pregnancy early, you just tackle my endometriosis and let me freeze my embryos or oocytes for a later date. For women with stage 3 or 4 endometriosis who fail to conceive following conservative surgery or because of advancing, so if they are conservative conservative surgery is done and they fail to become pregnant, or they have an advancing reproductive age more than 35 years, or there are other reasons, tubal factor, male factor, you can directly go for IVF. For women who are found to have asymptomatic endometrioma and who are planning to undergo IVF, there is insufficient evidence to suggest that removal of endometrioma will improve. So if there is a patient who comes to you and says, now I need to go for IVF, there is no evidence saying that you have to remove the endometrioma prior to going for IVF. However, if the endometrium, so the cutoff point of the size of the endometrioma is 4 centimeters. Surgery should be considered for these patients to confirm the diagnosis. So one of the good things about surgery will be that you will confirm the diagnosis histologically, to improve access to follicles during oocyte retrieval, and possibly to improve ovarian response. The patient should be made aware that extensive ovarian surgery could compromise ovarian function and diminish the response to ovarian stimulation, and this should be made, make them understand it. So after the ASRM guideline came in 2012, the H3 committee got together in 2014 and created the H3 guideline, which was an extensive guideline. It is very good to read it if you are interested in it. And the same guideline was modified by our FOXY 2016 GCPR. In infertile women, so what did the H3 say? That they looked at all the main research papers. So Tuman's paper in 1997, Nelson's paper in 1993, Warburg's paper in 2006, and they concluded that in infertile women with stage 1 or 2 endometriosis, clinicians may perform IUI with control. So they felt that IUI with controlled ovarian stimulation is better than IUI alone or ovarian stimulation alone. And in infertile women with stage 1 to endometriosis, clinicians may consider performing IUI with controlled ovarian stimulation within 6 months. So if you do surgical treatment, within 6 months, you must try IUI with controlled ovarian stimulation. That will give you the best outcome of pregnancy. The influence of endometriosis on the success rate of IVF is not unequivocal. The pregnancy rates after IVF were reported to be lower in patients. So does endometriosis really reduce the incidence of pregnancy rate in IVF? Overall, we have a feeling that yes, because the endometriosis has a lower ovarian reserve, lower number of oocytes, lower number of embryos, the pregnancy rate is affected. So you need more cycles to achieve pregnancy. So ultimately, you will achieve pregnancy, but compared to a patient which doesn't have endometriosis, if an endometriosis patient you undergo IVF, they need more cycles to achieve the pregnancy. However, there is a huge database from SART and from HFA, that is from US and UK, which has shown that patients of endometriosis, if you compare with normal patients, the outcome following IVF is similar. GnRH antagonist protocol may not be inferior to G. So we had an understanding initially that GnRH agonist is a better protocol, but not so. An antagonist protocol can give equally good results. The H3 recommend the use of ART for infertility associated with endometriosis, especially if tubal function is compromised or if there is a male factor. So other factors, just like the ASR and the H3 also said, if there are other factors, it is better you go for IVF. In infertile women with endometriosis, clinicians may offer treatment with ART after surgery, since cumulative endometriosis recurrence rates are not increased after controlled ovarian stimulation. So if there is endometriosis, clinicians can offer ART immediately after surgery as per the previous ASRM guideline. In women with endometriomas, clinicians may use antibiotic, and this is very important. So when we are doing the oocyte retrieval, there is a high chance of infection, and prophylactic in our group, 48 hours. I initially had to admit them for 2 days, but at least for 1 day. So I tell them that 24 hours IV exposure of antibiotics has to be there if a patient has got endometriosis or hydrosalpinx or a previous history of PID. So in these patients, we admit them, prophylactically give them antibiotics. Clinicians can prescribe GnRH agonist for a period. So there is a big school of thought which says that 3 to 6 months of GnRH agonist suppression followed by endometriosis may give better results. So, but you know what happens if you do this kind of suppression? When you actually start stimulating the patient, the number of oocyte yield is lesser. So in our group, we don't do that. We go directly for antagonist stimulation, pick up the oocyte, create the embryos, freeze them, accumulate. Suppose there is less embryos, we'll do one more cycle, accumulate them. Then we will give the agonist for 2 months, suppress the endometriosis, because endometriosis has got an immunological and an inflammatory component. So we need to suppress that component at the endometrial level and the implantation level, and then we may need to do the transfer, and we get fantastic pregnancy rates. In infertile women with stage 1 endometriosis undergoing laparoscopy prior to treatment with ART, clinicians must consider the complete surgical removal of endometriosis to improve the live birth rate. Although the benefit is not well established, you need to remove the whole capsule, but you must be careful not to remove the ovarian tissue along with the capsule. The effectiveness of surgical excision of deep nodular lesions before treatment with ART in women with endometriosis associated infertility is not well established with regard to reproductive outcome. However, they may request surgery because these patients have a lot of pain. As I think Dr. Kamini Raj said, if there's got a lot of pain, you have to offer them surgery. You can't just neglect and ignore that. But you do surgery, you be conservative, you don't damage the ovary, etc. In infertile women with endometrioma larger than 3 centimeters, this is where the thing comes. If it is more than 3 to 4 centimeters, there is no evidence that 6-stage prior to treatment with the ART improves pregnancy. In women with endometrioma larger than 3 centimeters, the HCGDG recommends clinicians only consider cystectomy prior to ART to improve endometriosis associated pain or the accessibility of follicles. If there's a large, more than 4 centimeters, you may not get enough follicle number. You may not be able to access all the follicles. There may be a lot of pain. In those patients, you should remove that. The GDP recommends that clinicians continue to treat women with a history of endometriosis after surgical menopause with combined estrogen, progesterone, or tibolone at least up to the age of natural menopause. Why I have told you that sometimes with these extreme surgeries, they may land up in surgical menopause. You may have to continue treatment. In women operated on for an endometrioma, clinicians should perform ovarian cystectomy instead of drainage and electrocoagulation, as I had told you before, for the secondary prevention of endometriosis associated dyspareunia, and non-menstrual pelvic pain. So this is very important. So in cystectomy, what are the precautions you have to say? Minimal use of electrosurgery, precise hemostasis, use of alternative methods of electrosurgery, such as you can take sutures or you can use the various hemostatic agents, and you have to be very careful. So you minimize. You can use a laser also. A CO2 laser with a penetration of 2 millimeters is very good for this kind of surgery. But I don't know whether this video is. Can you see the video working by any chance? I think I'll just skip this. So what about the recurrence? Because there are some patients who may recur after the treatment. For infertile women who have stage 3-4 endometriosis and have previously had one or more infertility operations, straight away IVF is the method of choice. You don't again go for a surgery unless, of course, she has got a severe pain or it's a very large endometrioma. What is the about effect of cystectomy on the AMH levels? And this is a study by Wong et al. In 2019, a recent study where he studied 171 patients and the cyst size was more than 7 centimeters. And he used coagulation or suturing. And there was definitely, he concluded that women with large bilateral stage 4 endometriosis had a significant fall in the AMH levels. However, there was only a short-term decrease in women with single unilateral cyst, which may recover completely within a year's time. So if a patient asks you, this is good for counseling purpose. He can ask you, what is what about oocyte cryopreservation? So this is a 10-year observational study by Anna Kobo, which has come out in Fertility Study in 2020. And she has done 485 patients, and fertility preservation is a valid option for these patients. This is our Naina Hedden in 2007. We had removed, she had endometrioma. We never touched the endometrioma. It was quite a large one. It was Dr. Nandita's patient, and we retrieved the oocytes. I personally froze the oocyte myself. Those days I used to do my treating myself. We froze the oocyte, and after 8-9 years, she came back and she had the first time baby with the frozen oocyte, and another 2 months also. So 3 children she had after frozen oocyte. It is shown that as the number of eggs per age to get at least 1 euploid embryo. So as you grow older, you need 5 oocytes between 35 and 37, 7 oocytes between 38 and 40, 10 oocytes between 41 and 42, and more to get a normal euploid embryo. Euploid means chromosomally normal embryo. And this is a paper by Wu et al. In February of 2019, where he has shown the and all the groups at present is the only indication for pre-IVF surgery are a severe pelvic pain or and to improve access to follicular size. So if there's a size of more than 4 centimeters, yes, you may. Other indications like 2 million count, male factor is there. Other factors that you go directly for IVF. Then you do the ovarian reserve test, AMH and AFC, and you also do the tubal testing. So you know what the patient's reserve is. Then if you have a mild or minimal endometriosis, you have a moderate or severe disease, you can either go for a laparoscopic route, do surgical treatment, do controlled ovarian stimulation with IVF, and if that fails, go for IVF, or you can go directly for IVF route. So it is up to you how you want to do it. So what is the plan? How do I do it? So what I do is, you may give a depot GNR exposure because I told you the number of oocyte yield will go down. So I go directly for GNRH antagonist cycle, and I do the classification of response. So you have either a high responder or a normal responder or low. Many of these patients of endometriosis may have been normal in their response. So I would give them a normal stimulation protocol. Many of them may have a poor ovarian reserve. If that is the case, I will give them a protocol based on the poor ovarian reserve. In our group, we don't use testosterone gel for endometriosis. In all other poor responder patients, we use testosterone gel, we use DHEAs and growth hormone, but in endometriosis patients, I don't like to use them. I give antibiotic prophylaxis. I avoid cyst puncture. If it is actually follicle fluid, then I would change the needle and use a new needle to perform so that I get other follicles, and we keep the oocytes separate in the lab. We don't mix the ones which are contaminated with endometriosis with the ones which are not contaminated. We do ICSI for all because there is the cumulus cells may have a lot of factors. Endometrium, so you can take an endometrial biopsy and do a B cell CLL lymphoma endometrial expression marker. This is a surrogate marker which is positive in patients of endometriosis or in patients of unexplained recurrent pregnancy loss or unexplained infertility. And nowadays, if this marker blindly gives kind of and then do the embryo transfer. As I told you, the poor responder is very important, and we use the Bologna criteria. I told you, preservation if AMH is less than 1.5, and I'll say, okay, we will give you medical treatment as per Dr. Sanjeeva Reddy's treatment, blah, 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 all that. And if you have a very severe disease, a lot of pain is there, and we can't help it, we'll go in with the surgery. If I go in, okay, I will take out few ovarian strips of cortex as well. I will also do an oocyte retrieval, preserve your oocytes for future use. Women wanting to preserve fertility. There are many women who are married, but they don't want children. You can't say that, okay, Arey Baba, you got endometriosis, please get man, please have kids. You may tell them, but they may not accept it. So in this also, I'll do the AMH. If AMH is less than 1.5, I'll offer them fertility preservation. If the stage 1 to asymptomatic patient comes to me, treat it as unexplained, because normally an asymptomatic stage 1 to you, how will you make a diagnosis unless you do a laparoscope? So you treat it as unexplained infertility, do tubal testing followed by control ovarian stimulation and IUI. And if that fails, you can go directly for IVF if your unit policy is that, or you can go for a find endometriosis, treat it. If you find a cause, you treat it, then you can offer 1, 2, or 3 cycles of IUI before going in for IVF. What about stage 1 to symptomatic patients? I'll treat them with laparoscopy followed by control ovarian stimulation for 6 months, 3 to 6 months. And if it fails, I'll do IVF. What about stage 3 and 4 disease endometrioma? 3 options are there. I can do laparoscopy for all. I will correct it. I'll conserve the ovary. I'll do everything in a nice fashion. If I feel like, I'll also remove some of the strips of cortex and preserve them, and follow it by an IUI for 3 cycles. And then if that fails, go for IVF. The other option is if there is no pain or if the size is more than 4 centimeters. If there is pain or size is more than 4 centimeters, I will obviously do a laparoscopy, do the surgery, do 3 IUI cycles followed by IVF. If there is no pain or the size is less than 4 centimeters, then what will I do? So I can do 2 things. I told you, either I can do a laparoscopy or I can go for directly conservative approach. That is, I'll go directly for IUI, and if that fails, I'll go for IVF. So there are 3 divergent ways in which I can treat this patient. Recurrent endometriosis patients are also there. If they come to me, I'll say directly I'll go for IVF. Only if the size, again, when I see if the poor lady has got a size of 4-5 centimeters and I will not be able to access the ovary, or more than 4-5 centimeters, they don't develop follicles in the ovary. So I would go in, just decompress and come out, and then immediately start stimulation in the next cycle. And ultimately, I will freeze all, cool everything, give GnRH analog for 2 months. Following that, I'll do frozen transfer. And so very rarely we will do fresh transfers in this patient. Now, one last thing before I go, because I and you, majority of us are simple doctors who have simple surgery. So my advice to you, because I've done 30 years of work in my career, and whenever you call an external surgeon to operate with you, he is very bold in his surgical approach, and many times they do complications. I've had 3-4 complications where other surgeons, I will not say all big surgeons, they have come and done complications, and I had to handle the complications. So it's very important, and I know that 70-80% of you, if you do laparoscopic surgery, advance you will call someone from outside. It is very important that you have to control their hand. That's the most important thing. You have to tell them, no, don't operate there. Don't do this. Don't do extensive surgery. If they do, take the bowel away from you, it is going to get stuck again there. It is of no use. So you should be conservative in your approach, because you will land up with a bowel injury. You will have a peritonitis, and they will go away, and you will have to face the medico-legal complication, because ultimately patient is going to say, doctor, I came to you. I don't care who operated me. So this is very important. Don't get carried away by surgery. You have to be very conservative. I always tell my assistant that if there's a difficult case, send it to your competitor. Don't do it yourself. You have to practice defensive medicine. And this is my advice, my update to all of you who are looking at this presentation. Endometriosis is a very dangerous disease. I have seen in my life such life-threatening complications following surgery with this disease. It's like a cancer. It has a lot of adhesions, and when the bowels are getting separated, a lot of perforations occur. Okay, so you have to be very careful. Thank you, Kuldeep and Madam, for such a wonderful session. I also learned a lot, and I hope that I keep coming and learning from you. Thank you.
Thank you, Dr. Rishikesh, for your wonderful tips. I think our listener must be very happy after listening your talk, and you have given all the tips to these on this endometriosis. Of course, we all know that it is a very enigmatic, it is a complex problem, and how to deal with the assisted reproduction when they come for the fertility, how to counsel them and how to speak to them that this is the problem with you and it will take 2 months, 3 months, because everybody wants the immediate action of fertility.
You have to be very careful of the endoscopic surgeon. They are very aggressive. They create a lot of complications. And especially if it's not their patient, they will be more aggressive and create more complications.
And now you are speaking anyway. Endoscopists are very, very difficult to manage. But once the hand starts, you need to be in a
I was also the president of the Endoscopic Association, so I know how both the groups are,
must be knowing very well.
But the IVF people are more conservative and the endoscopic surgeons are more aggressive. But now, slowly, the endoscopic surgeons have realized that we need to also be conservative. And there's no need of taking the bowel away, doing this, getting the colon away. He's going to go and get stuck again there. What is the use of doing all that? We need to have a good access to the ovary. We need to have the decompression. We need to have, I forgot to tell you that there's a Doness technique where you leave the hilum, when you are taking off the...
I will talk about that.
When you take the hilum area, there's a lot of loss of oocyte. So you leave the hilum away. So there may be slight increased incidence of recurrence, but on the other hand, you get a high incidence of retention of the oocyte. So you can have that technique. And I always wanted to buy a CO2 laser. If there are younger people in the audience, I would like to tell you, if you buy a CO2 laser, and you can have a very large and huge practice, because if you use a laser, a lot of people will come to you because you can conserve. You can do conservative surgery on the ovary, and that you can be your USP.
Thank you, Rishi. Thank you, Rishi. It was really wonderful and a lot of tips you have given. And now another domain, as far as the secrecy of endoscopic surgery in endometriosis is concerned, there could be none other and no better person than Bhaskar Pal. Rishikesh has already highlighted, if you are not comfortable in your surgery, or your surgeon who is doing the extensive surgery, you have to restrict. But as far as Bhaskar Pal is concerned, I think he is the right person to comment on the restrictions of surgery in endometriosis, how he does conserve the ovary, and what is his tips whenever you are dealing with what you call endometriosis, whether it is grade 1, grade 2 and grade 4. So let us listen from Dr. Bhaskar Pal. He is a well-known endoscopic surgeon, senior consultant gynecologist at Apollo Glen Angels Hospital, Kolkata. He chair RCOG India East International Committee, honorary secretary general, Indian Association of Gynecological Endoscopy. He was vice president, Foxy, president-elect, Bengal of St. Gynae Society, and maybe in future he will be your candidate for President Foxy. Bhaskar Pal, it is all yours.
Thank you. Thank you, AOGD, Dr. Mala Srivastav, Dr. Mamta Dagal, and thank you very much, Kuldeep, for inviting me, and all the best for your elections.
Thank you.
I will start with your 3 common questions during the pandemic. Okay, the first one is, when will the pandemic end? And the second one is, am I audible now? Am I audible?
Yes, you are.
And
audible.
the third one is coming, and that is, can you see my screen? Can you see my screen?
Yes, very
Excellent.
well.
Now, this is the topic that Kuldeep has given me, that endometriosis, endoscopy, yehi hai right choice. Unfortunately, my answer is not going to be an unequivocal yes. And I think most of it, what I am going to speak, is very much in lines of what Rishikesh has spoken. There is a saying that never ask a barber whether you need a haircut, because the answer is always going to be yes. But I guess as doctors, we are not barbers. But the biggest decision that you need to make as an endoscopic surgeon in endometriosis is, as one of my seniors used to say, that residency is 3 years. In 3 years, you can learn how to operate. And then it takes you 10 years to decide when to operate. And then in some people, even in their lifetime, can't even make the decision when not to operate. I think as a surgeon, the most important decision is when to operate and when not to operate. Now, I will straight go into the point. And what do we mean by laparoscopic treatment? Now, there are two kinds of laparoscopic treatment in endometriosis. When you have a peritoneal endometriosis and when you have an ovarian endometriosis. GIE, Dr. Alka Kriplani has already spoken about. Now, I would think that in endometriosis, there is nothing called a diagnostic laparoscopy. As Dr. Ramani Devi said, that we need to move into clinical diagnosis, and earlier we were taught that we need to put in a laparoscope to diagnose endometriosis. No longer. I think we should move into clinical diagnosis. And I think the most important part of laparoscopic treatment in endometriosis are three. And if you look at the current tertiary guidelines, and you will get the ethos of that. Number one is delay the first laparoscopy as long as possible. Number two is your first surgery is your best surgery. So it should be done by somebody who's experienced at doing an endometriosis surgery. And number three, throughout a life, try and limit the number of surgeries a lady with endometriosis would require. Now, in laparoscopic treatment for peritoneal endometriosis, what we do either excise the lesion or we ablate the lesion. Now, whether you excise or ablate depends on what you're doing it for. With excision, you will get a less recurrence rate in terms of pain, but whether you excise or whether you ablate, the fertility rate is going to be the same if you're doing for infertility. If you are doing peritoneal endometriosis and pain, you have to remove all visible areas of pelvic endometriosis, and you have to restore the anatomy by division of adhesions. Now, this has been for ovarian endometrioma. For a long time, we've been taught that more than 3 centimeters should be operated if the patient has pain. Unfortunately, the current thinking challenges that, and it challenges in the fact that if somebody with a larger ovarian endometrioma wants to be on medical treatment and wants to defer the laparoscopy, jolly well you can defer the laparoscopy. But obviously, a 6-7 centimeter endometrioma will not respond to medical treatment, and patients would need to know that this will most probably require a surgery. But after knowing that, if they want to delay the surgery by being on medical treatment, because these days you have medical treatment which are pretty effective and can be used for long. Similarly, earlier it was taught that any ovarian endometrioma which is more than 3 centimeters, which is 4 centimeters or more, with the patient is going for ART, which should be operated. And what was the biggest worry? The biggest worry was that during egg collection, oocyte retrieval, it will get mixed with the endometriotic fluid, and that will hamper the pregnancy rate. And the current, if you look at the current studies, and they show that there is absolutely no difference in the endometriotic in the pregnancy rate, whether there is contamination of the follicles with the follicular fluid and the endometriotic fluid. But what is important is the aspiration of the cyst is not recommended. It's a very poor treatment, because whether you do an ultrasound guided aspiration or a laparoscopic aspiration, it is going to refill again immediately. There are essentially 2 types of surgery. One is you can open the cyst, drain the cyst, and then ablate the wall. Aspiration, irrigation, and either a diathermy or a laser. What it does is it causes very little ovarian damage, but the problem is there is a risk of incomplete surgery, so patient will get an early recurrence. When we will do that, we will come to that when we take a situation by situation. The other option is to do an excision and a cystectomy. Now, what is an excision? When you enucleate the entire cyst wall. And if you're doing a primary surgery, if you're doing a surgery for pain, your excision and cystectomy is your preferable option, provided the ovarian reserve is good, because there is less recurrence with that. But an integral part of the surgery is restoration of the tubo-ovarian relationship. There is less pain if the patient undergoes a cystectomy. There is less recurrence risk, less recurrence of dysmenorrhea, dyspareunia, non-menstrual pelvic pain, but there is more reduction of ovarian reserve. And there are studies which have showed that when you've done a cystectomy, there is a reduced ovarian response on stimulation. There's reduced ovarian volume and antral follicle count. But whether it makes an effect on the IVF pregnancy rate or the take-home baby rate, I think the jury is still out. There are different studies show different things. But there are risks of severe ovarian damage. And that is why Dones proposed this, that for large endometrioma, you can do a combined excision ablation, where the follicles are the most at the hilum. So what you do is you aspirate the cyst, irrigate the cyst, enucleate the cyst wall starting from the periphery till you reach the hilum. And when you reach the hilum, you use a cold scissors to cut the cyst wall and then vaporize the hilum just with a diathermy laser. So this gives you a good balance in achieving a good surgery as well as not damaging the ovary too much. But you know, you have to be very, ovarian damage at surgery is more surgeon dependent rather than procedure dependent, which means just same as what Rishikesh said, that we need to minimize the use of energy. Now, what happens is indiscriminate diathermy because the patient is bleeding. Now, why does the bleeding occur? Because people are not in the correct plane. So it is important to stay in the correct plane. It is important to minimize the use of energy. We can try things like vasopressin infiltration. We can use a suture. But what is important is we need to limit the use of energy sources, especially monopolar. Now, I will take 4 situations and what is the role of laparoscopy in that. One is asymptomatic endometriosis. Now, asymptomatic endometriosis and laparoscopy, the question will only come when somebody is undergoing the laparoscopy as a part of the fertility workup. So essentially, if you see endometriotic spots there, they should be excised or ablated. And the evidence, as we said, for fertility, the outcome is more or less the same. But if you find the endometriotic implants, they should be removed when you are doing laparoscopy for infertility. What happens if we see an asymptomatic endometrioma? And when do we see an asymptomatic endometrioma? I think all these people now these days have a health checkup, especially the pre-employment and during your working, you get an annual health checkup. And many a time we come across a hemorrhagic cyst or an endometrioma with a patient who's completely asymptomatic. Now, what is important is to see how good the sonologist is so that you can differentiate between a hemorrhagic cyst and an endometrioma. If it's an hemorrhagic cyst, then it can be managed expectantly with a follow-up ultrasound 6 to 12 weeks later. If it is an endometrioma, then it is quite logical to put the patient on a medical therapy and not jump into a laparoscopy. As Rishikesh said, you cannot tell the patient, please go and get pregnant now. But what is our job is to tell the patient that what is the effect of endometriosis on infertility, and if endometriosis on fertility, and if the patient is not very keen to go for a pregnancy in the near future, then of course discuss the options of egg freezing with her. What do we do with endometrioma with pain? Unequivocally, the patient would require a laparoscopy. But if it is a small endometrioma, we can initially try medical management. The problem with medical management is the recurrence risk could be pretty high the moment you stop the medical management. If we are going for laparoscopy, we need a preoperative assessment of ovarian reserve, that may be by AMH or that may be by an antral follicle count. But large endometrioma with pain would always require surgery. Now, if it is an unilateral endometrioma and if it is a first surgery and the ovarian reserve is good, I would always go for an ovarian cystectomy if the patient presents with pain. Now, what do we do if there is an endometrioma with subfertility? The questions we need to ask ourselves: is there an associated pain? If there is pain, yes, the patient needs a laparoscopy. What is the ovarian reserve? If the ovarian reserve is poor, then we would rather not do a laparoscopy, or even if we do a laparoscopy, we would be very careful to be conservative and not do a cystectomy. The size of the endometrioma is very, very important, and that is where I do not do IVF, and so I have the benefit of 3 or 4 very good infertility specialists, and I actually send the patient to them and say, please look at the size of the endometrioma, do your own ultrasound and decide whether you want me to operate on her first if the patient doesn't have pain. If the patient has pain, of course, we'll have to operate. If the patient doesn't have pain, I leave it to the fertility specialist to decide whether they want to go for IVF straight away or whether they want me to take the endometrioma out. And that would essentially depend on the size and the location of endometrioma, and they would have to decide whether they can access the ovary and get follicles. And again, means I don't think there is any reason to take 3 centimeter or 4 centimeter as a cutoff. It has to be on a case-by-case basis. Of course, anything which is 6 or 7 centimeters, most infertility specialists would be unhappy to go for an IVF straight away. They would want us to operate. Again, if it's a subfertility, we need to look at whether it is unilateral or bilateral. If it is bilateral and somebody presenting with subfertility, I would possibly be reluctant to do an ovarian cystectomy on both sides because there'll be a lot of loss of follicles. But what is important is we do a collaborative decision making with fertility specialists. And if it's a small endometrioma, usually ART would be preferable before doing a laparoscopy if there is no associated pain. This is a very, very old chart from the Journal of Human Reproduction, and I find this very, very useful. When somebody presents with an endometrioma along with infertility, how do you decide whether to go for surgery or to go for expectant management? Now, these are the points which favor surgery, that the patient has not had a previous surgery, the ovarian reserve is intact, the patient has pain, it is a monolateral disease, or if you are suspecting there are sonographic features of malignancy like solid areas, or it has been a rapid growth. Whereas you'd rather go straight for ART if patient has had a previous surgery, which means it is a recurrent disease, if the ovarian reserve is damaged, if there is no pain, if it is a bilateral disease, if there are no sonographic features of malignancy, and if it is a stable size endometrioma for quite some time. What do I do with a recurrent endometrioma? Recurrent endometrioma, if it is not very big, I always try a medical management first. It is a nightmare to operate on a recurrent endometrioma. And so we have very good molecules at the present moment, so we can use a medical management. What if the patient presents with subfertility? My personal choice is that try and avoid a surgery and go for an ART. Again, if it's a large endometrioma, sometimes we'd have to operate. Then we would send it to, there is no role, I think most of the speakers have said that there is no role of medical management when in endometriosis when somebody presents with infertility. The only exception is, as Rishikesh was talking about, that they'll give GnRH analogs for a few cycles before doing an embryo transfer. If a recurrent endometrioma presents with subfertility, the first choice would rather be an ART. If the patient presents with an ovarian cyst, then it depends on size. If it is a large ovarian cyst, I would rather go for surgery. If it's a small ovarian cyst, so which means recurrent endometriosis, normal ultrasound, only complaint of pain, medical management. Recurrent endometriosis with subfertility, no pain, preferably ART. Recurrent endometriosis with ovarian cyst, if it is small, I'll go for medical management and try and defer the surgery as much as possible. If it is large, it will require a surgery. But please remember, surgery for, Dr. Alga Kriplani was also speaking about this, surgery for recurrence requires surgeons with experience and the surgeons with expertise for surgery for endometriosis. Combining presacral neurectomy reduces the recurrence, whereas laparoscopic uterosacral nerve ablation has no role in management of pain. But at a surgery for recurrence, we need to expect additions. We need to explain the risk of urinary tract and bowel injury. We need to do a proper counseling. We need to discuss the risk of colostomy, just like what Dr. Kriplani said. And we need to have a bowel preparation. And we need to dissect out ureters. And madam said a very valuable tip that you start from healthy area and gradually try and move into the diseased area. But it is very important to dissect out the ureters and to open up the spaces. So nothing is the right choice. Treatment of endometriosis needs to be individualized. Combination of surgical, medical, and fertility treatment is the best option in most situations, depending on what the patient is trying to achieve. Thank you.
Thank you, Bhaskar. You have actually summarized whole session in 15 minutes, and that was really wonderful. That was really wonderful. Dr. Sudha, would you like to make a comment? Dr. Sudha, are you there? It was really wonderful, Bhaskar. It was actually my contention that whenever we are having a laparoscopic surgeon on the panel as a speaker, usually it is one-sided. But I think you have kept a real balance as far as the endometriosis surgery is concerned. You have really highlighted the points where you will prefer to avoid surgery and where you will go for surgery. So I think you have already conveyed a lot of practical points in your lecture, and for that I really thank you very much. There are few questions. Most of the questions they have already basically answered in our lectures. There is one question: how to prevent developing endometriosis? Dr. Asha, will you like to take this question? How to prevent developing endometriosis? This is from Dr. Sudha Selvi.
How to prevent endometriosis from progressing or developing?
Developing.
Developing endometriosis. I think the main reason is girls getting married late and girls postponing their pregnancy. But is it possible to reverse this trend now? It's very, very difficult. So it may be advisable to have patients with dysmenorrhea on OCP. Once again, I cannot say that everybody should take OCP. That's not possible to suppress endometriosis. So I suppose there is no particular way of preventing the progress unless there are some leading causes like obstruction to the flow, like a uterine anomaly, etc. How else do you prevent it from developing?
Actually, it cannot be prevented because there are multiple factors in the etiopathogenesis of endometriosis. But certainly, if you make them aware, because it starts in adolescent and then present after 6-7 years. So if you are able to make adolescent aware that this is something which we need to look at early stage, so progression can be halted. That is what is required also. So patient, when they enter into reproductive life, they do not have a very serious or severe nature of disease. So that is what is important. But as far as the prevention of endometriosis is concerned, it is really very tough because it is multifactorial. So that is my take on this question. And anybody who wants to add? Bhaskar, you will like to add something?
No, I think it is absolutely what you said. I think endometriosis cannot be prevented, but progression of endometriosis can be prevented. And if we have to do that, this is exactly what Dr. Sanjeeva Reddy, Dr. Asha Rao, and Dr. Ramani Devi has said. We need to make people aware, especially in adolescent endometriosis. One study shows that there was a mean period of time before it was diagnosed, between 7 to 9 years. Patients had average seen 4 to 5 doctors. So while before the diagnosis was made, so people with dysmenorrhea, chronic pelvic pain, these are the candidates where we can stop the progression or delay the progression by putting them on oral contraceptive pill. You cannot put the entire population of oral contraceptive pill, but I think it should be, the aim should be on prevention of progression or delaying the progression.
Yes, I think that answers that question. Another question is there from Dr. Dibya. What conservative treatment can be given after endometriosis surgery? I am not, it is not very clear whether the patient is infertile or having only pain for which she has undergone surgery. So, Bhaskar, I think
I will take that question. I will take that question. If the patient is presenting with infertility, with or without pain, we will not give her any medical treatment. That patient, I think Rishikesh has said that very, very clearly, that patient, depending on the stage of endometriosis, either goes for a little bit of time or goes for an IUI for 3 cycles and then goes to live. So if it is infertility straight away, there is absolutely no question of giving anything. If it is only for pain and we know that recurrence in endometriosis is guaranteed, then what are your options? Now, people have given adjuvant treatment, and adjuvant treatment in the past, what people have given is 6 cycles of GnRH analog, and they have shown that giving 6 cycles of GnRH analog, you can delay the recurrence, or you can even you can delay the recurrence, you can decrease the recurrence risk also. Now, unfortunately, most of us do not give 6 cycles of GnRH analog. Many people give 3 cycles of GnRH analog, which are neither here nor there. What has used to happen is, for most of us, we give the patient who can afford GnRH analog for around 3 cycles, and for patients who couldn't afford, we'll give them continuous oral contraceptive pill for a few months. Now, please understand that adjuvant treatment is something which you give for 6 months. And there is also a concept that comes in endometriosis called secondary prevention. And what is secondary prevention? You keep a patient on something for a long time so that you try and prevent recurrence and delay recurrence. Secondary prevention, there are studies on secondary prevention where people have given, if the patient is not planning a childbirth, you could put an LHC IUS at the time of laparoscopy, or you can put the patient on an oral contraceptive pill for 2 to 3 years, or you can even put the patient on Dinoges for 2 to 3 years. So if the patient has completed a family and it is essentially endometriosis for pain, yes, there is a reason for doing a secondary prevention.
Yeah, regarding suppression by GnRH analogs, even if you give it for 6 months, at the end of 2 to 3 years, there was recurrence in about 20% of patients.
Yes.
But if you can give Dinoges for about 3 to 4 years, the chance of recurrence are only about 5%. This is one of the studies.
Yeah.
So long-term Dinoges is pretty good. Or you have to put a LNG-IUS.
Yeah, I think for recurrence after surgery, if the patient is put on continuous Dinoges, because in reproductive life there are not many studies which have shown that the safety of Dinoges is not there. So they can be continuously put on Dinoges for a longer period. Or in those patients, there is another paper and there is another suggestion to reduce the recurrence. Initially, you give 6 months of GnRH analog and then continue Dinoges. So recurrence rates are found to be better, means less in this group. So that is another suggestion where you can combine both GnRH analog and Dinoges.
But I will tell you, Dr. Kuldeep, many studies has found that there are the chances of decreased BMD. So these people should have the add-back therapy also cyclically.
Yes, yes.
The issue is that I think what has happened is that with Dinoges now we have 5 years data of safety and they're reasonably safe. But I think the study that Dr. Sanjeeva Reddy was quoting is called the Visado study, which has shown that especially in adolescence, there has been some degree of bone loss, much less than with Depo-Provera, much less than with GnRH analogs, but which means that we need to be careful with long-term Dinoges, especially in women who are adolescents and women who are above 40. These are the patients where we need to be careful about the bone loss. So we need to keep a look. We need to keep an eye on their DEXA with a DEXA scan at the BMGs, and definitely put them on calcium. And as Madam said, something stronger if they have a low BMG.
Very right.
Yeah.
Yes.
This is very interesting question from Dr. Bandana. For diagnosis, which modality is better, laparoscopy or MRI, if the patient is billing for conception? Dr. Asha.
For diagnosis, I would say the best modality is ultrasound. Is the first line of diagnosis.
Yeah.
And in extreme cases, perhaps you resort to laparoscopy for diagnosis, though it used to be the gold standard. Today, the value of laparoscopy is more for therapeutic purposes and not so much for diagnostic purposes. So use it with the rationale, not for each and every one. A young girl should not have 4 to 5 laparoscopies in her life.
Yes, I think Bhaskar has also highlighted very nicely that laparoscopy is to be deferred as much as possible. So the message is very clear. Use ultrasound very judiciously. If you are having a doubt, go for MRI. And still, if you are having, because for endoscopy, there are very definite indication which is already highlighted in our previous presentation. And most of the questions which I am having in my hand, there are a lot of questions. They are already actually answered in various lectures. So if there is no other question, I will like to have a one-line comment from all the speakers who are present at present, and then Dr. Sudha Prasad to sum up. Dr. Asha, will you like to give a single line message to our audience for endometriosis treatment, whatever you want to say as a endometriosis committee chairperson?
Yeah, I said it at the end of my lecture that my goal this year is think endometriosis and fight endometriosis. So what the mind does not know, the eyes do not see. So one has to be suspicious, one has to be aware of the problem of endometriosis and do ultrasound or MRI as and when required. If necessary, a therapeutic trial, and refrain from laparoscopies as much as possible. So be conservative and be kind to them.
Dr.
This is my message.
Yeah, I think there are essentially two messages. The first message is if it is it is a laparoscopy for endometriosis with infertility, please take an opinion of a fertility specialist at the start. And even if it's a laparoscopy in a young girl who will plan childbearing in future, please remember fertility and do not be too radical in the approach. That's number one. And number two is very much like contraception. You know, one upon a time we said in contraception, delay the first, press the second, the third never. Similarly, I think delay the first laparoscopy as long as possible. The first laparoscopy is the best chance, should be done by an experienced surgeon. And then we have very good medical management modality. Try and space the future surgeries as much as possible.
Thank you. I think this is very, very nice message for all audience. Anybody else is there? Dr. Ramni, are you there? Rishikesh has already left. So Dr. Sudha, please sum up. I think it was really wonderful. So please sum up today's program. We have already crossed 650 plus login. So it was really wonderful connecting with everyone.
Excellent program, Dr. Kuldeep, because if this many viewers from the key role speakers have given their opinion about the endometriosis, I think our listeners has really benefited by this, and it is an excellent program. I just want to give a message that if some adolescence comes, so you have to go through the history and make the diagnosis. You have to really think. If your mind thinks, then only you can make the diagnosis. So there should not be any delay in diagnosis. Then only if she comes early, then probably it will be easier to treat this patient, number one. And I had a patient with a 15 years old adolescent girl and had a nearly 16 centimeter endometrioma. So if it is this much of big endometrioma, probably if you start thinking of medical management, it won't be, because patient was in absolutely agony. So these are the patients who will require the laparoscopic surgical treatment, but one has to be very, very careful that from which side it has been arised, and the other ovary for her future obstetric, for your future fertility, it should be very well neatly, it should be there. And if we are really doing the ultrasound for the diagnosis, which is the best modality to diagnose endometriosis, simple 2D ultrasound, it works very well. If you see carefully, if the person is doing themselves only, then 2D will give the very good picture, because endometriosis, the endometrioma, is having a very neat, clean picture of endometriosis, which can be diagnosed, and if required, one can do the 3D. And MRI is a very remote one. If the point of MRI comes, it is only in the deep endometriosis where you diagnose some nodule, and probably that may not be possible. That MRI will be required in those patients only. And once the patient has failed the medical therapy, there are lots of medical therapies, starting from the contraceptive pill to progesterone only, the SERMs, and finally the Dynogest, levonorgestrel, IUCD. So if it all fails, then the patient lands up for laparoscopy. If she is in a fertile phase, so please do AMH. Please see what is her AMH. It will be benefited by when you are doing the counseling to these patients, and do laparoscopy. But you should know how much you have to remove, what are the anatomy, because anatomy is absolutely distorted. And Alka said very clearly that you can land up in problem with the ureters and the bowel. And Dr. Bhaskar Pal has mentioned very, very clearly what safety has to be applied for the endoscopy. So one should be very careful when you are treating these endometriotic cases. So I hope this will benefit. All the key holder has given the very good messages, and our viewer will have the good take-home messages. Thank you very much.
Thank you, Dr. Sudha, for moderating, and I really thank you for doing all hard work. Finally, this is last message from Sana. We have touched 700 logins. So it is really wonderful. despite having so many webinars on Sunday, we have done a nice job as far as the endometriosis is concerned.
And I'd like to tell you, best of luck for future election. I hope people must have listened to you and they will be doing a good job for you.
Thank you so much.
Yeah, congratulations.
Yeah, finally.
Congratulations, Kuldeep. It was a wonderful webinar. Points were brought out beautifully. And wish you.
Thank you, Dr. Asha. Thank you very much. Finally, I request General Secretary of AOGD, Dr. Mamta Dagar, to propose a vote of thanks formally and say a few words regarding this endometriosis, if she wants to conclude in her own way. Before I hand over the mic to Dr. Mamta, I will personally like to thank Ankita, Dr. Ankita, who has really done a very nice job as far as the coordination and anchoring is concerned. So thank you, Ankita. Sana has done a really wonderful job in conducting whole session without any problem. So thank you, Sana. Bharat Sidam, thank for all your academic support. Dr. Mamta, to conclude a formal vote of thanks.
Yeah, good afternoon, everyone. So we had an humongous response to this webinar today, despite being Sunday, as we see 700 viewers. It's fantastic. At the end, it is my humble duty to propose vote of thanks to everyone. I'm extremely thankful to our guest of honors, Dr. Ramani Devi, Dr. Mandakini Meg, and Dr. Parag Binewale for being here today and encouraging us. And to our esteemed moderators, Dr. Kuldeep Jain and Dr. Sudha Prasad, for choosing such an excellent topic, a very important topic of endometriosis, and for expert opinions. And to our star speakers, Dr. Asha Rao, Dr. Alka Kriplani, Dr. Kamini Rao, Dr. Sanjeeva Reddy, Dr. Hrishikesh Pai, and Dr. Bhaskar Pal for your very informative and excellent deliberations. And thank you, Dr. Ankita, for anchoring the show from beginning to end. And thanks to Sana and team at the back end for smooth running of the webinar. And last but not the least, I'm thankful to our viewers for being with us today on this Sunday. Thank you, everyone.
Thank you so much.
Yeah, doctor, thank you very much. It was really a wonderful experience serving for you all, twice. Thank you very much. I hope we continue with the same.
And Sana, you have communicated very well. To me, at least, I know. So thank you.
Bye-bye. Bye-bye, Dr. Asha. Bye-bye, Bhaskar.
Bye. Yeah. Bye, Dr. Kuldeep and Dr. Sudha.
Bye-bye.
Thanks, Dr. Kuldeep. It was a nice learning experience. And
Yeah,
we
Dr.
enjoyed
Mala.
all the deliberations, scientific deliberations, as well as all the nice videos. Thanks, Dr. Kuldeep and Dr. Sudha ma'am.
Thank you, Dr. Mala. Thank you, Dr. Mala, for giving me this opportunity to host the program under AOGD. And you are doing really wonderful job as far as the academics are concerned. So keep it up. Thank you.
In your presidency, you are doing AOGD.
Yeah, it is really wonderful.
Wonderful.
Dr. Sudha, is it you're wearing your Bengali sari? This is true?
You can see I'm in sari.
Okay.
Thanks, everybody.
It's nice to
It's been a nice learning experience.
Otherwise, at home, you do not.
Yeah, correct.
In a formal. So I thought this is the right occasion to be in a formal. Thank you.
Okay, bye-bye.
Okay, bye-bye.
Well done.
Thanks.